that the meeting today will be audio recorded, but we also have some of the local media in who will be filming parts of the meeting as well. Just to remind members and those in the public gallery that you're welcome to use your mobile devices, but if you can keep them on mute throughout the meeting, that will be really appreciated. And it's not permitted to take photographs or anything of the meeting either. So I have one apology, sorry, from Alan Robinson. I'm not aware of any others. I think we might have Colin maybe joining a little bit later. So I suppose just under Chairperson's business, I want to thank the Southern Trust for hosting the committee today. We had a number of visits to the hospital and to the acute care at home team, which were absolutely fantastic, really, really excellent. And I'm so appreciative, and I'm sure other members will agree, to all the staff for their time today to give us a really good insight to the really positive work that is happening right now. We often hear just the negative stuff and what's going wrong, but there's some really, really good work that is undoubtedly improving the health and well-being of patients right across the north, but indeed in the Southern Trust. So we're all very grateful to that. This morning we saw the theatres, the medical ambulatory unit and the acute care at home services, as well as the paediatrics theatre. So it was fantastic. So we really, really do appreciate it. And as a committee, we endeavoured from the very start of this mandate that we wanted to get out and about and see what's happening on the ground and use that information to help us in our role. So thank you all for that. If I could refer members then to item number 3, your draft minutes of the meeting held on the 16th of January, page 6. Are members content with the minutes? Agreed. Thank you. I have no matters arising at this stage. Does anyone else have anything to raise? Okay, thank you. Item number 5 then is our first briefing with the Royal College of Surgeons of England, and it is in relation to elective care. If I could refer members to the clerk's memo, page 19, and their papers, which are from page 24 of your pack. So I'd like to welcome Niall McGonigle, Royal College of Surgeons Northern Ireland Director, and Mr Mark Haynes, Consultant Urologist. So thank you both for coming. We're delighted to have you here, and I think it's actually very timely given the visit we did this morning. So really, really keen to hear what you said. So we have approximately an hour for this session. If I could just remind members, because we do have quite a lot today, and I want to get through and get as much covered as we can. It's 2 very important briefings we have. So if we could just remind that when we're asking questions and try and keep them timely. The session today will be covered by Hansard. And if we could just invite you to make your opening remarks, and then I'll open up to the floor. So thank you to members.
Thank you. Good afternoon. Thank you, Chair and Committee, for inviting us today to talk about surgical hubs. As a brief summary and to set the scene, we remain with a dire situation in terms of waiting lists in Northern Ireland. The most recent published figures in November 24 show that there are 109,506 patients awaiting admission for inpatient or day case care. The majority of these are under general surgery, trauma and orthopaedics, ENT and urology. Median waiting time is between 47 and 51 weeks. The reason for the 2 figures here is because of the differences between the reporting mechanisms, as you probably know, between trusts, with the ongoing rollout of the EPIC and Compass digital system, which has had effects on abilities to produce data over a period of time. Overall, 82,181 people, or 75% of the waiting list, are waiting more than 13 weeks, and 52,935, or 48.3% of patients, have been waiting over 1 year. The members will be aware that the target being that 55% of patients should wait no more than 13 weeks, and no patient should wait more than 1 year. These are amicable targets to have set, but clearly we are falling significantly short of what we want to achieve for our population. I do not think I need to remind you about the ongoing crisis in our emergency departments and unscheduled care, which is having a knock-on effect on elective care. We continue to see demand in our hospitals exceeding capacity. Many surgical hubs in the UK were developed and under development prior to COVID. And during the global pandemic, it became increasingly clear that utilisation of surgical hubs, or green sites, or green pathways, allowed for and supported the delivery of elective care. The utilisation now increasingly recognises that in recovery, these are able to deliver on elective waiting lists, and that is primarily what they were designed around. We understand that approximately 2/3 of the patients on our waiting list are waiting for day case type procedures, with the remaining one-third requiring inpatient or longer stay admission. Whilst our waiting lists are long, we must acknowledge that there have been small incremental reductions over successive quarters in which no doubt surgical hubs have played a role. To explain what a hub is, a surgical hub is a dedicated, ring-fenced elective care facility with resources and staff that are distinct from unscheduled care. They excel in the delivery of high-volume, low-complexity work, with examples being hernia repair, cholecystectomy for gallbladder disease, joint replacement, cystoscopy and urotoscopy. There's no specific model set for a hub or how a hub should work, and several models have emerged over the years, ranging from a site that is completely and physically separated from all other operating flows to a hub that is within a business-as-usual site. The main principle of a hub is being used is to ring fence for both beds and staff so that care can continue to be delivered despite pressures elsewhere in the system. The three main models being a hub within a hospital, a standalone hub, or a specialist hub providing specialist surgery. All too often, elective and unscheduled flows compete for pooled resources, be that theatre space, staff, equipment, or pre- and post-operative beds. Hubs aim to prevent that. At present, there are two dedicated day procedure centres at Lagan Valley and Omagh hospitals, which have between them treated 27,000 patients from October 2020 to October 2024. There are three elective overnight stay centres at Daisy Hill, which we visited today, Mater Hospital and South West Acute Hospital, and between them they have delivered care to 15,000 patients between April 2023 and October 2024. Additionally, there is a dedicated orthopaedic hub at Musgrave Park Hospital, and they have treated 2,000 patients between September 2022 and May 2024. As part of our written submission, we have advised the Committee of the Health Foundation analysis of surgical hubs in England, which we believe provides supporting evidence to the validity of the model and is extendable to Northern Ireland. As of August 2024, there were 108 surgical hubs in England, with the planned opening of a further 26 by the end of 2025. Briefly, some of the key findings were that those trusts that had a hub pre-pandemic undertook 11.25% more elective surgery than they would have without a hub, but also, and more importantly, there were shorter hospital stays, adding to the overall efficiency of the system. Further, looking at 31 trusts with newly developed hubs in the aftermath of COVID, there was a 21.9% increase in activity for this high-volume, low-complexity work. Early evidence is also coming from the University of York with the Measure study, which is a 4-year programme being rolled out, which commenced in 2023, evaluating the high-volume, low-complexity hubs. We have provided limited data on these because it's not actually published yet, it's being provided to us. But the provisional results do show that surgical activity increases by about 20%. There's a reduction in length of stay in hospital by about 9%, and there is a significant effect on waiting lists. It is clear that the hub model works and works well, but it requires investment, support, and an ability to grow and change. But obviously, none of that is deliverable without an appropriately trained, reliant, and resilient workforce that Mark will talk about. My final remark would be that we are all here because we care. We want to see a health service and well-being of our population. We want to see a healthcare system that delivers for the people of Northern Ireland. All of us, though, must continuously strive to reduce the effects of the constant lurching from one crisis to another that causes harm to both patients but also to our healthcare's greatest assets, its staff.
Thank you, Niall.
Thank you. Thanks, Niall. As Niall touched on there, I was just going to touch on the workforce element. So just by means of reference, in January 2024, the College published the Advancing Surgical Workforce Census Report. Just some Northern Ireland specific figures from that. So within that workforce report, we found that 53% of Northern Ireland surgeons had considered leaving the workforce during the past year. 91% of those aged 55 to 64 said they plan to retire within the next 4 years. and 62% of Northern Ireland surgeons who responded cited a lack of access to theatre as a main challenge facing the surgical profession. Again, 66% also said burnout and stress were their main challenge. Within that census report, a number of recommendations have been made, which included trusts developing policies and guidance which beneficially impact the well-being of surgeons, tackling bullying, harassment and sexual misconduct and enabling flexibility and less than full-time working, improvements in the working environment, including providing places to rest, hot meals and dedicated places for study, and increasing training numbers across all surgical specialities and prioritising training opportunities. Within the hub model, I think there are a couple of things just to highlight. Obviously, the development of a hub of hubs where surgeons aren't finding their theatre access is being closed off because of the impact of unscheduled care. That helps to increase the theatre access. It's important that we ensure that trainees are facilitated in being able to attend the hubs in this. This isn't a consultant-delivered only service. It has to enable training. And we have to make the model of working fit with what is realistic for surgeons. It's okay for a surgeon to travel 2 hours to and from work for a short period, but is that a deliverable 30-year job plan? I was going to... Niall's touched on the waiting list. The other thing just to mention is the vacancy data. We know that across Northern Ireland Health and Social Care there are a significant number of vacancies, over 5,000. Within there are also vacancies at consultant level in the surgical workforce and at other grades below consultant level. So it was around 300 you mentioned. Yeah, so around 300 vacancies in total for surgical staff.
So it's consultants across, not just surgery.
Oh, consultants across, sorry, not just surgery.
Okay.
Yeah.
Okay, thank you for that, Mark. I suppose just, a couple of questions, and it's really good to even get those figures because recruitment is probably our biggest challenge and retention. And you've outlined even the percentages of people who've been considering leaving, and then again those even bigger percentage of those who will be leaving who've made the decision to retire. In terms of what's coming in then behind, are we confident that those will be replaced, or do we see that is a massive challenge, that particularly around people retiring at consultant level, that given, we heard some of the waiting lists this morning and what that looks like and the impact that has on people's lives, given that we're going to see quite a huge swathe of consultants or surgeons retiring, what do you see coming through that will potentially help to?
Well, we would talk about the 3 R's, so recruitment, retention and retirements.
Yeah.
Yes, retirement is becoming a major issue. As Mark said, 91% of consultants or surgical staff in Northern Ireland aged over 55 when we did our census 3 years ago, intend to retire within the next 4 to 5 years. So that is a massive amount of very senior, very experienced staff. Not all consultants are the same. Senior consultants can deliver a lot more, so we have to be very cautious about them leaving. Is there a flow back in again? No. Recruitment numbers, unfortunately, not just in Northern Ireland but across the UK, have remained stagnant over a number of years. In fact, a lot of them have just been released today. In the last couple of days, there's a lot of anxieties amongst trainees and stuff about not getting training numbers as well. So we're not meeting those. We're not in a position that we can deal with the people that are coming out, potentially out of a system, and fill them with people coming into a system.
Yeah, and that's, I suppose, the concern. And are we, I know it's certainly probably a question more for the department as well, but are we planning for that? Are we trying to look at why those challenges exist in the first place? Why are people not wanting to come into the field and trying to deal with that in advance?
I don't think it's that people don't want to come into the field. It's training numbers are set, so each year you get a certain number of trainees into each surgical specialty. Those are sort of out of the hands of the colleges. Those are within Northern Ireland, within NIMDA, the Northern Ireland Medical Dental Training Agency. They are, though, generally set across the whole of the UK, and we have national selection. So, for example, in my specialty, cardiothoracic, you are not appointed specifically to it. You are appointed to a training programme in Northern Ireland, but you're not appointed in Northern Ireland. You're appointed across the whole of the UK. For that, those training numbers, again, they've not increased over a number of years. So we know that we have a shortfall. Yeah. I think one of the other things is that we do need to start looking at workforce planning and ensuring that the people that are coming out of training are fit to fill the gaps. So, for example, the way it might work at the minute is that surgeon might go into general surgical training and decide to become a breast surgeon, but you might have 6 that choose to do that when you actually need 4 or 5 colorectal surgeons. And we've not been managing the workforce as well as we could from that perspective.
Yeah, okay, so it goes back to that whole, the broader piece around workforce planning right across the health service, but specifically where we could see really major issues if this isn't addressed soon. I'm going to move on just within the briefing papers, and it's something we've talked about before, is that there is a real appetite to move to kind of those 7-day sessions, and we've had these conversations this morning just when we were in Daisy Hill, in terms of how you could have an increased capacity and really put a real dent in the waiting lists that are currently there. But I understand that that's not as straightforward as it may seem. So I suppose just to kind of get an understanding of what some of those barriers may be and what we could do to try and address that, because I think if there's an appetite there, then we should be doing everything we can to try and move to that if it means that we can improve outcomes.
I mean, the GARF data for surgical hubs would say that they should be working at least 14 hours a day. That's the aim. 48 weeks in the year, 6 days a week. And most of our hubs are not achieving that at the minute. We need to therefore ask why. A lot of it is down to staffing issues. We are dealing with a workforce that is stressed, burnt out, morale is low. We've staved off a few industrial actions on the basis of pay parity with the rest of the UK. So this has already been sort of addressed in Northern Ireland, we've talked about before, and it has been seen across the Water in England stuff as well, in that we're saying is when you have a workforce like that, it's very difficult to start increasing. So it's very difficult to move into having 6-7 day working, because you're actually asking your staff to work more and more and more. So there are limitations from that. Filling those gaps is very difficult. At the minute, with some of the hubs and stuff, we are already reliant on locums. Part of the policy is to try to reduce the number of locums as well, which is certainly a very good economical thing to do. But again, it's about trying to fill those gaps in service. Okay,
and I suppose, would it be fair to say that if surgeons or surgical staff get more opportunity to do what they're trained to do and use their expertise, that would actually attract and maybe stabilise a lot of staffing issues as well if we were able to move to the 7 day? It
absolutely would. One of the things that was reported in our census previously is that over about 50 to 60% of surgeons, and that's both at consultant and at training grade as well, are unhappy in their jobs because they don't get access to theatre.
Yeah.
We've produced data that showed that in Northern Ireland, when you look at consultant surgeons, they spend, depending on which trust they are, which specialty they're in, about 20 to 30% of their normal working week operating.
Yeah.
Which I don't think anyone would disagree. It seems a bit peculiar to have somebody trained to such a high level, they've spent so long training, to be, I suppose, an expensive commodity and not really use them.
Yeah, no, and that came up, I suppose, in our discussions this morning too, around, particularly if there's staffing issues and you have to cancel surgeries and then that reduces theatre time. My last question, just in relation to, I suppose, specialist surgery, and it's an issue that I think we're all hearing more and more about in relation to obesity services and bariatric surgery. And I've had constituents that I've dealt with. I think with the growing number of people who are going abroad to have some of these surgeries because they can't access it here. And a couple of weeks ago, the committee met with the Northern Ireland Obesity Coalition, Professor Miras, and we had it was actually, I learned so much from them in terms of, how transformative it would be if we had a regional obesity management service in place and an ability to carry out bariatric surgery. So I suppose from the Royal College's perspective, is that something that you've been looking at or hoping to see?
Well, we've always supported it, and whenever there was moves to sort of introduce it around the SWA, we were very supportive of that, and it's very disappointing that didn't happen. Yeah. It is sad that we are in this position because we do hear all these horror stories about people going to not just Turkey but other places and having surgery and having complications and coming back and having to deal with those complications. But the fundamental is that you have to ask yourself is, why are people going there and having it? It's because we don't have a service here.
Absolutely.
We have forced those people into it. Yeah. They haven't chosen to go there. Yeah. They have been forced to go there because we haven't given them a realistic option here.
Yeah, and I think the key thing that I learned with the meeting with the coalition is that the reasons for people requiring that service in the first place are so nuanced. There's so many different aspects to it, and in terms of we're always looking at the pressure on health service and the need, people maybe requiring more primary care all the time. If we're able to provide that service, then that takes pressure off elsewhere. People are living well, and all the other health conditions that are associated with obesity could be eliminated or managed much better as well. So there's so much to it. I think it's definitely something that we should be looking at very closely. And I think what the warning that we got that day as well was that this is something that's coming down the tracks quick and fast that could cause a real crisis across the board. So I think it's something we could really look at and try and see how we could. I know that there's a strategy group in place, and I think a consultation right earlier last year. I still think we're in 2024. Apologies, but I'd be keen to see, and we can maybe follow some of that up with the minister as well. Yeah. So thank you for that. Okay, I have Linda.
Thank you, Chair. We're not using microphones or anything. Don't need press in.
No, they're just recording.
Just checking. Sorry,
I should have
my
just
own
said
hearing
as well.
is not good, so I'll take it for granted.
Just before, because on that point, I suppose because we have media and they are recording, so when we're reverting to people for questions later in the session, give it a wee bit of a pause in between just to give people time to move around the room as well. So apologies, thank you.
And speak loud because I really have a hearing problem. Mark, I think I caught most of what you said, and it's not your fault, it's mine. Someday I will get the hearing aids that I clearly need. Just a couple of questions. Mel, so see the hub model. Will there be any knock-on effect in terms of a positive knock-on effect from those? So obviously we know the kind of things they'll deal with, and it is that very seriously needed surgeries, but less complex surgeries. Will that have any knock-on effect then for the more complex surgeries that do need to happen in the likes of our, Royal Hospitals, Craigavon, places? So, and I'm thinking specifically, to be honest, just because it's something that has been raised again with me today, is the like of paediatric spinal surgery. Mm-hmm. Is there a potential for improvement in that service if we had a greater capacity to move other things out to or will that not really have an effect because it's more taking pressure off the...
There is an expectation that it would, on the basis that a lot of this sort of, we talk about the low complexity stuff can be moved out of specialist centres, out of some of the tertiary hospitals as we call them in Belfast, as an example, therefore creating more capacity there because you're not doing that type of surgery there, you have somewhere else to do it. So it does do that. There is an ongoing project to develop, particularly where you're talking about Linda there, about paediatrics, to develop an actual paediatric hub. There has been a workshop in the last week or two. Unfortunately, I wasn't available to go to that. So there is plans to sort of now start moving to have a hub for paediatrics as well, because we know we have a paediatric waiting list as well. And last count, we reckon in the region of about 7,000 children waiting for inpatient care on those lists as well. So again, if you're moving that out of places like the Children's Hospital then you're freeing up capacity to do that more complex work. But the other thing is that as surgical hubs grow, you move in complexity. So whilst you might look at some of the surgical hub numbers of cases done and stuff, and you can see every so often it maybe goes down a little bit, it's not because they're doing less, it's because they're taking on, as they grow, more and more complex work.
Okay, and I mean, I have specific, but I'm not going to ask in this meeting, I think, just in relation to specific cases. But so in terms then of the hubs themselves, we've already talked about the workforce challenges. We know that there are workforce challenges. Do we have any idea of how we might overcome some of them? So it's not just, we know the surgeons is one element of it, but it's obviously our theatre staff and all of the staff that would be needed in those hubs. Do you think those things can be, or is there a plan in place from the department or from the trust to actually overcome that you're aware of?
Well, I think the department has started to look at that more recently again, and the issues that sort of exist for medical staff, they don't just exist for medical staff and surgeons, they exist for all staff within hospitals and within our healthcare. And it does get very basic. Those cross-cutting components is, can you park your car at work? Do you have appropriate rest facilities when you want to take your break? Can you get a hot meal? So if you start a shift at 1 o'clock in the afternoon and don't finish till 10, 11 o'clock at night, can you get a meal? Those are the things that are really important to people, is, travel time as well. And it's about that, about making staff feel valued. And I know we talk an awful lot about, pay parity and things like that. There's an awful lot of other ways of incentivising staff and making them feel valued and making them feel part of a system, and a system that appreciates them as well. Mark, do you?
No.
Actually, when we met with junior doctors previously, they said to us pay is only one element of the challenges, and not to single them out, but Alton Galvin came up quite regularly during those conversations as having some of the worst facilities for staff. I mean, not even somewhere to have a cup of tea, never mind could you get a cup of tea, you wouldn't know where to have it, and having nowhere even to put your coat, or it's and the facilities, even in terms of those who had to stay overnight, spend time away from their families. So I think you're absolutely right. My last question then, I'm going to ask two on my last one. So one is are there examples of best practice in other places? So whether that's in other parts of these islands around I think the workforce in particular, because I'm concerned at what you're saying about those more experienced leaving and the numbers of trainees are as they are. But even if we have more trainees, if we don't have people to train them? We're going to have a real problem. So are there examples of best practice of how we can actually deal with that in other parts of the world? And the positions that are vacant. So we've had it raised with us before by RCN and others that the nursing positions, the vacancy rates that we're being given is what is being advertised, those jobs that are being advertised, that are being actively recruited for, not what the actual vacancy rate is. So the number of people that we actually need to make our health service work. Is that the same for surgeons?
A couple of questions there. I'll start with examples of best practice. Yes, probably we've spoken before about GIRFT. Get it right first time. GIRFT is an organisation that comes in, looks at what you do. It does it in as best as can as a non-judgmental way, and saying, you may go into an organisation, a hub, and say they're doing 4 hernias in one day, and you'll say yes, but this other hub is doing 8 in a day. And says, why are you only doing 4? And they look at the factors that are causing that. And it may be that from that you get the best practice learning from somewhere else to say as well, have you thought about doing it this way instead? So there is a lot of that, and that is something we would like to see throughout Northern Ireland, is the learning and sharing of where one organisation, one department, one service is doing very well. They share that with someone else, because it's not that the other group are not doing as well by any construction themselves. It may be that there are blockers that they've recognised or not recognised. Maybe the blockers that they've recognised that they've not been able to change. Another organisation can tell them, well, why don't you do it this way? You're right about the training, and to sort of encompass 2 questions there that you asked is, Yes, when it comes to junior doctors, it's time that they actually get to do the training. You've got to remember, junior doctors, or the resident doctors and doctors in training, are there for two reasons. They're there to provide a service, which is our NHS model, but they're also there to be trained to be the next generation. You will hear me going on all the time with the Royal College of Surgeons is, no training today, no surgeons tomorrow. We have got to realise we've got to train people to keep coming through that process, and if we don't do that, we will not have a workforce down the line. We have got to ensure that time for senior doctors, consultants, is set aside to train their juniors, to work with them and make sure that they are progressing. If we are pulling them in 10 different directions and they can't train, we're not training the surgeons of tomorrow at all. It's about making sure that they have appropriate study facilities. It's about making sure that they get off to do their studies. It's about making sure that they get courses, etc., paid for, and not having to pay for a course and then maybe get the money back 12, 18 months down the line. You know, again, it's back to that being valued.
And I was just going to say, just to touch on the two things. So on the trainees, the hubs have a big role to play in that, but the trainees have to be freed up to get to the hub, because the nature of the hub is they're not going to get disturbed for any emergencies and things. They can be trained surgically in the hub. And just on the GIRFT comments, at least 3 specialties across Northern Ireland have had GIRFT visits, and Northern Ireland reports published by GIRFT on how services can be done. So they are available. I think trauma and orthopaedics, gynaecology and urology have all been done.
And
to my knowledge, and paediatrics, yeah.
Okay, thank you.
Chair, and just to thank you for that last point on them paying for their exams and some of their training. I think that is something we need to raise with the department, because it's an issue. It was raised with us by the junior doctors, and I can't get my head around it, to be honest with you.
Yeah, no, absolutely, okay, and thank you for that. Danny?
Thank you, Chair. Thanks for that, both of you. And I think you described it as a dire situation at the start of your presentation. And certainly for people, those more than 50% of people that are waiting longer than a year, it still is. And certainly those are our constituents, and we hear about them all the time. I've personally heard of a lot of my constituents who are being forced into that situation of having to pay privately or look about going away. And, you know, that is a terrible and very, very costly thing for them to do. We have a 2-tier health system in Northern Ireland. We absolutely do. A couple of questions just based on what you said. Now, we're in the throes of winter pressures again. I'm just wondering, what has been the impact this year with the hub model in place? What has been the impact on the waiting lists being worked down during our winter pressures? Has there been a difference this year? Has the waiting list, working down the waiting list, been more protected? Have you seen a bigger difference?
Can't actually answer that at the minute, Danny, because we wouldn't get access to those statistics yet until the department produces them.
Sure.
And it'll probably be a few months before we get that. But anecdotally amongst our members, they feel as though with having hubs and being able to deliver that, you know, elective care through alternative means without hospitals, then they've been able to do that. Yeah. I work in a specialty that is delivered in a, you know, Belfast Trust in a tertiary. And I can tell you that sort of the pressures on the hospital with admissions through the last couple of months with flu, the COVID, respiratory syncytial virus has had a significant effect. It has put immense pressures on trying to get patients in, trying to get cases through. Now, we have managed very well, but there is no doubt that has had a knock-on effect.
Okay. I think you get incrementally different pressures. So if you go to your standalone day procedure unit like Lagan Valley, things have been able to roll and work as previously, and it would be the same in Omagh for that. If you then move to the hub on site, I work in both Belfast and Southern Trust, so I've been here in Daisy Hill in the hub here, and we've been able to carry on working, but there's been more challenges with pressures on some patients having to be moved around because of the emergency department pressures. Okay. When you then move into your specialist sites like RVH, where you have big emergency take, and as Niall says, his specialty, the pressures are higher again. So.
And just to cover another point in the question you asked as well, there is a lot of data from Merseyside showing that surgical hubs in GIRFT, that hubs actually reduce health inequalities. Patients in the most socially deprived areas tend to deteriorate quicker on waiting lists than other people. So if you deliver their care quicker, you prevent them from getting a lot of the comorbidities associated with it.
Okay, thank you. One of the things we've heard today, that the waiting lists seem to be bizarrely counted, and I think they're counted differently in different regions as well. And the waiting list may also still include people that have died, people that have become too frail for their surgery, or even the ones we were talking about who have gone privately. Are we painting a false picture here? Are we getting an accurate picture of the waiting list, or do we need some sort of regional Northern Ireland-based re-evaluation of the waiting lists?
I think that's a very good question to ask, is do we know if all of those patients sitting on waiting lists, as you say, still need an operation? Is the operation that they're in for still the correct operation? Yeah. One of the things that our members will report about the surgical hubs is they may have been asked to operate, as an example I would give, for cholecystectomy for gallbladder disease. So somebody was added to that list 3 years ago and they're asked to now do them in a surgical hub. Well, that patient has maybe been in 4 or 5 times with cholecystitis, inflammation of the gallbladder. The gallbladder is now really stuck. It's really difficult operation to do, not suitable for a surgical hub. The other thing is patients have deteriorated on those lists as well. They've got other things. And as an anecdotal example of that, one surgeon spoke to me and said that somebody put on a list like that to come in, but they had 2 heart attacks in the intervening period as well. They were no longer suitable for that. So there is a very important thing about validating the waiting list, keeping up them to date for 2 reasons. It means you know what actually is on the waiting list and who needs what done. But it's also giving information to patients. They're also not feeling forgotten about. If you're saying, we know where you are on a waiting list and this is where we think it's going to be, patients feel empowered because they say, well, I know what this is going to be. At the minute, a lot feel that they're just being put onto this nebulous waiting list in Northern Ireland. All they ever hear is the negativity about it, and they're going, I don't know if this is ever going to happen.
And one of the things, one of the things that we got was patients getting a letter saying, do you want to still stay on the list? You know, and that's the only communication they get.
Yeah.
Sorry.
So I was just going to come in on that sort of clinical validation or clinical reassessment. Really is how I'd view it. There is a start to that, but not embedded in practice. It's currently not embedded in practice that once a patient goes on a waiting list, they get a planned review. And it's really important that those patients who've been on these waiting lists for a long time, we need to know, are they fit for surgery? Do they still want or need surgery? Is the procedure they were originally listed for the right procedure in the right environment? My specialty, there's a good example in terms of male prostate surgery. The options available for treatment while patients have been on the waiting list have changed hugely. So patients who've been on the waiting list for a longer period of time were never considered for day case procedures that are now available. So by reviewing them now, we're able to channel them patients into the day procedure units where they can get treated.
Yeah. So that regular review is necessary.
But that isn't embedded in practice, and it's, you know, we're talking about inpatient day case surgical waiting lists here, but remember we've got the same waiting list for new referrals, for follow-up appointments and everything else. So it's I often refer to things as a game of whack-a-mole. Right. Which one are you going to hit?
Give us Mike. Yeah. Just with the census report that you referred to in your presentation, I remember that coming to committee, I think, early last year. And I remember it being quite shocking and hearing that we were facing that crisis. Have any of those numbers changed anecdotally? You know, do you think those numbers have got better? Are we going the right way?
We wouldn't know that at the minute. We are doing another census running that will probably start in potentially about toward the end of 2025 to report in about 2026 that we should be able to do it. Anecdotally, it's difficult to say. There are a large number of when we come to the retirements of senior surgeons, there's been a bit of a delay on the sort of the partial retirements and the retirements. Because of that, some may have gone into retirement as opposed to trying to take a partial retirement, which is, you know, still working for the NHS but just working less hours. And because there has been movement on that, I see that a lot will probably take partial retirement as opposed to full retirement, which will, provide those sort of very senior people still working in roles within the hospital.
All right. One last question, just about Encompass. Obviously, it's something we hear very regularly about on the committee. The rollout's ongoing. We've I believe it's coming here in this trust in May. Have you seen benefits of the rollout of Encompass across the trusts that have already done it? And do you see the benefits specifically about the data that is being collected?
I think the having all the data in one sort of place so that it can be looked at instead of having to go into trusts and stuff like that is very good. Mm-hmm. One thing that Mark would probably want to talk about is the fact that because he works between different trusts, Encompass is very good because he's able to follow the patient better when they go from his trust to Lagan Valley. They can do like this. Encompass, I think, is a great system. I think having electronic records are great. Mm-hmm. It is a one thing fits all, which will never work for everyone. Mm-hmm. But I think that overall it has those benefits of being able to follow patients a lot better. Okay. You don't lose medical records. You're not sitting in clinics going, why is this patient here? Because I have a blank sheet of paper and I have no access to any notes about them as well. So yes, it has its negatives, but primarily its positives.
Would that make regional, addressing waiting lists regionally, would that make that a lot easier?
It should be able to do that, yes.
So, okay. No problem. Thank you very much.
Yeah, thank you, Danny. Nuala?
Thank you very much for your presentation so far. I have a couple of questions just around the training numbers, robotics, elective care framework and the protected time. So just following on from the training numbers versus vacancies and commissioned posts. With regards to who, because you outlined that it was a UK-wide in terms of the training allocations, who actually then, I'm assuming it's the department, correct me if I'm wrong here, of Northern Ireland that commissions the posts for the consultant surgeons here for each specialty? And are you aware if that's based on, kind of population health or the trajectory of what's needed? And is that up to date and fit for purpose currently?
It's probably a bit more complicated than that because various specialties either recruit locally or nationally.
Okay.
And by that I mean is, so for example, like trauma and orthopaedics, they run a recruitment process in Northern Ireland. They set the number of trainees that they want per year in Northern Ireland and they recruit to that in Northern Ireland.
You say they? As it, who do you mean
well,
when you say they?
NIMDA.
Okay, NIMDA does.
Okay. For other specialties, for example, my specialty cardiothoracic, there is no local recruitment. It is recruited nationally. You put in a bid to say whether you will be able to take a trainee or trainees or not, and that is decided nationally how many trainees you would get. Where we have a slight difference and an opportunity potentially is for core surgical training. So that's where after the foundation years, surgeons come in and start sort of doing their basic surgical training. Core surgical training used to be administered nationally, and out of about 40 posts at times when it was administered nationally, we may have got 6 people into posts, and that was because people just didn't want to come to Northern Ireland. When it moved to being local recruitment in Northern Ireland, you essentially filled all of those posts every year. During COVID, we had to go back to national selection. Same problem again. 9 people said they would take up a job out of 40 in Northern Ireland, and I think it was only 6 actually turned up. So there is a lot.
But every other year doing it locally?
Every other year it's almost been completely filled.
So one of the challenges with national selection is the appointments are based on points and they go to the top candidates. They then get to select the posts they want, and people who maybe already have their families and property and roots in England, Scotland and Wales.
Yeah.
It's more to look at moving here than it is to look at, say, me when I moved from Cardiff to Sheffield for my training number.
But we are attracting people when we do it locally. We're attracting them, and then there's...
Because they're applying knowing that they're looking at a job in Northern Ireland.
Yeah. Okay, that helps to understand it a bit more, and it is rather complex, but I think it's useful to know in terms of who allocates and commissions places are. Just moving on to then the issues of robotic-assisted surgery. I understand it's used in the field of urology in Northern Ireland mainly, but in terms of keeping up to date with advancements in technology for our surgeons, what areas should we be looking, to prioritise it with regards to robotics? We've heard it now from a number of times. We heard it earlier today on the visit here, and we've heard it from a number of other surgeons across the different trusts. So I just want to hear your thoughts on it.
Yeah. So as you say, currently in Northern Ireland, the primary user is urology. Mm-hmm. There are some procedures in Belfast Trust being done, I believe, colorectal and some gynae, but limited numbers. We're in desperate need of a robotic surgery plan for Northern Ireland that covers most specialties and covers how it's going to be delivered across all trusts. We can't have a robot in Belfast that attracts new consultants to Belfast but leaves the other trusts struggling to a point. We need access to the robot for general surgical procedures in every trust, for gynecological procedures in every trust. We need access to the robot for cardiothoracics in RVH.
And is it a different one per specialty?
Most is done, so there are multiple different, I could talk for a long time about robotics. There's lots of different consoles. The most commonly used console is the one that we currently have in Belfast City Hospital. There's a benefit to using a single console because people aren't then training to use different consoles in different places. And most procedures, most robotic-assisted surgery procedures were developed on that robot first. And so what would make sense is developing a plan for how robotic surgery is going to be delivered across some specialties, across all trusts, and use it as a recruitment carrot to attract and retain consultants.
And why is it just? Why is this one robot? And it doesn't look like a robot, but I'm seeing in my head right now. I'm assuming, but why do we have this one robot in the Belfast Trust? It's focused just on urology, and not just, but mainly. I did put in a written question into the department that 599 patients who actually had robotics-assisted surgery, 513 were male and 86 female, and the majority of which on urology. So why is it just this one?
So robotic-assisted surgery and the evidence for and the development of actually largely commenced in urology, and it was prostate cancer surgery that it developed in. And so the robot was originally commissioned for prostate cancer surgery. So the vast majority of patients who have been treated on the robot in Northern Ireland have been treated for prostate cancer, and so are male. And that's where the evidence base for the advantages of robot-assisted surgery commenced. Within urology as a high-volume specialty using the robot, then urology then also branched into other procedures. And the next procedure that was commissioned here was kidney cancer, so partial nephrectomy. So that affects both genders. There's then other procedures that have then developed robotic training and robotics across other specialties. But the reason urology started is because that's where it started. That's where robotics started. And the reason is the male-female split is because prostate cancer is a very common cancer. I think we were around 150 cases treated surgically in the last year. So you get a lot of men treated on the robot.
No, I understand that. It's just quite a stark when it can be used in other specialties. It is a massive stark difference. What are we talking about in terms of costs for this to be rolled out across all trusts? If we are talking about, technology is not just the future; it's the now. So what? I'm not sure you might be able to answer that.
I think probably, Niall, the issue is that robotic surgery outside of urology is not a commissioned service in Northern Ireland.
Yeah.
And that's one of the big holding points at the minute.
And that's what the department...
In terms of costs, if you want me to go into that, the issue would be is that it probably is cost neutral in terms of individual cases with other cases at present. There is a significant financial thing, as Mark has talked about. There are several different platforms that you can buy but the one platform that's used in Northern Ireland would hopefully be replaced as well. A very similar system. It's the upfront cost is around $1 million.
Yeah, that's what I want
to
know.
buy the system.
Yeah.
It
and then
varies
training
actually.
the people.
So the upfront cost for a single console is around $1 million to $1.5 million, I think, depending on your setup. You can get a training console that sits with that, so you have a trainee trained at the same time, and that adds to that cost, and that's the ideal setup.
Yeah.
But again, it's a significant extra outlay to do that. But if we want to develop robotic surgery, we need to be looking at the robots. We need to be looking at how we train. Having a single console and surgeons swapping places is perhaps not the best way to train.
The other then things is the sort of the non-financial costs of not having services like this. Is we will train surgeons to a certain level in Northern Ireland. They may go off and do, and we are facing this at the minute, they will go off and do robotic fellowships elsewhere around the world. They will look to come back to Northern Ireland and say, why would I go back there? I can't do the job I've been trained to do. So we are facing the brain drain as a result of this. So there is this non-financial component that we really have to look at.
And it's something that we'll certainly have to follow up on, and we will.
So just on that was one of the main drivers behind the push and the commissioning of it in urology. Was we had a robotically trained surgeon who hadn't been able to access or use the robot for a number of years. Having the robot, we've recruited 2 consultants from posts in England and Scotland to come to Northern Ireland, and we've also been able to train our own trainees and retain them in Northern Ireland delivering robotic surgery. So that recruitment and retention, the robot works.
Okay. Thank you. I'll follow up on more after separately. In terms of the elective care framework, I don't think you were here last time when it was published. I can't remember the elective care framework. The update in May was published by the last time you were here.
Before.
So I just want to know if you, in terms of the priorities, because 10-year plan, we know that budgets are difficult at the minute, but with regards to your expertise and specialties, what would the priorities within that be for you, from your point of view?
I'm very keen to see priorities and stuff put in and longer term plans, because I think, as we were talking about in the opening statement, there was Northern Ireland is very reactionary. We wait until there's a crisis and then we do something about it. Like we have a winter crisis at the minute, and we're talking about how we would deal with elective care during it. We need to have these decided years down the line. One thing I would always say is you don't know where you're going to be in 5 years, or you want to be in 5 years. You can decide that. That means you've got the waypoints along the way. You've got to have 6 months, a year, 2 years, and it's only by developing those will you actually get where you want to be in 5 years' time.
And that's last time you were here, you did call for that roadmap to be established. Is the engagement then any better? Has it improved with the department and the SPPG and the Royal College, and feeding into the reconfiguration as well as framework implementation? I
think we've continued to feed into that. We've continued to give our views on that, and I think those are received well by the department.
Okay, that's positive.
Have we affected major change? I'm not sure yet.
Okay, that's positive to hear, and we'll engage further on that. And my last question, just as last time as well, we spoke about specialist services that only contain at Belfast, and I always I'm not naming them, I will forget some, like yours, cardiothoracic. Are they getting better in terms of them being protected? Is it improving with regards to unscheduled emergency takes priority, but with regards to elective and the surgical hubs and protecting the ones that can only take place at the Belfast, is it getting better?
I think we've touched on that already today, but yes, I would say that all services, hospitals are like a bottle. There's only so much you can pour into it, and if you keep filling it up with unscheduled care, you can't pour stuff in for elective and deal with it, and we're having that knock-on effect. We don't have access to the beds. It's having a problem. It is accepted that is a winter crisis every year, but when does the winter stop? When does the winter...
But what I mean particularly with regards to, have we moved away from any elective at the Royal where, it's not protected?
No, we still do elective surgery.
So I'm
through the
talking
Royal.
about the elective outside of the specialties.
Maybe just
So
I don't know if I'm making myself clear.
So actually, it just came to me there as Niall was speaking. We've forgotten to mention the other surgical hub in reality, which is the City Hospital, which doesn't have emergency admission pressures. And so for our major cancer specialist surgery that takes place in the City Hospital, we're not impacted. That's where I do my surgery in Belfast. I'm not impacted in the way Niall is for his specialty because he's at Royal Victoria Hospital.
I'm probably confusing with my question, but are we doing elective care in the Royal where they're not in the 4 or 5 contained specialties that can only take place in the Royal and nowhere else across Northern Ireland? Because I remember at one point that was a difficulty in terms of waiting lists and pressures.
Well, to answer, yeah, there are still 3 surgical specialties at Belfast within the Royal: cardiothoracic, vascular, neurosurgery. They are regional specialties, and they are only delivered within the Royal. Now, there is some stuff in terms of varicose vein surgery and stuff for vascular.
And are they?
And
what I'm asking is, they continue to be protected?
Are they ring fenced? No, they are not.
That's right.
Okay.
That would have been easier to just ask that. We got there in the end.
Thank you. Just before taking Diane, can just ask people if we can keep the volume up a wee bit, because it is a wee bit with the aircon. It's hard to hear sometimes. It's not like in committee we have the amplify of the microphone. These are just recording, so just keep that in mind. Diane.
Thank you, Chair. So just a couple of questions. Some time ago I asked a question of the Health Minister about the amount of time that surgeons actually spent in theatre, and that varied between 20 and 30% depending on the trust. There was a commitment in a follow-up that the department and the trust would work with yourselves to try to see how that could be improved in terms of access to theatre, nurses in theatre, cancellations because of emergency cases, etc. How has that worked out?
The simple answer is I don't think we've seen much change since we last spoke about that. Our rate limiting factor always remains capacity. It's so capacity to get into theatres for all of the surgical specialties remains the main problem. All of the theatre lists in all of the hospitals are kind of maximised based on the amount of staff that they have. The other thing we talked about was rotas and how they work and how the number of staff you have to do, so when you've got your numerator and denominator. But I would say that it hasn't necessarily changed since we last spoke.
And
that's disappointing.
Well, I was just going to add in the other factor in this is even if you wanted to increase the amount of time of a surgeon in theatre, you need to still provide the outpatient activity that they're doing, and we've got the same outpatient pressures. So without expanding the workforce with an expansion in theatre so that job plans can reduce outpatient activity and have greater theatre access, you're again playing that same game of whack-a-mole. You're stopping seeing people in clinic to do extra theatre lists.
So that leads us in almost a circular problem, in that access to theatre means that we will always continuously have longer waiting lists, and that the problem will go round, and then those will be impacted by what we call winter pressures, but in effect are pressures all year round in the health service. And it is disappointing because I had thought that the department were going to start to do some work to try to look at how that would, how we could work on that. Given also the fact that in health and social care we actually have higher numbers in the workforce than we've actually ever had before. So it is disappointing because we have to try to work out a system that does that. I will follow that up with, because I do think that is important. So that leads me on to my second question, which is, we have over 500,000 people in Northern Ireland waiting for a first consultant-led appointment. You've detailed the number of people who are waiting on surgery, etc., etc. Those are higher numbers than we've ever had before. So we will always have the ongoing emergency stuff that has to be done, but we have this huge backlog that we seem to accept as there, but we're not quite sure how to deal with it. Is there a way, and I don't know whether you've thought about this, I'm just throwing it out, that we look at the sort of the ongoing day-to-day work of looking after people in health and social care, but that we actually try to deal with the backlog separately by expanding, I accept, elective care hubs, but they seem to be at the minute only kind of nibbling at the edges of the backlog, not really getting to the heart of it. So what you as people at the cold face of this, what do you think should be done?
I think the word is efficiency, and that's kind of what we've been looking at, is the health service, and are we doing things as efficiently as we can? What do we come to you about that, about the hubs and about nibbling away? It's right, you're quite right. You might see the waiting list coming down a little bit. What you've got to think about in that as well, Diane, is you're not actually waiting, you're not adding to the waiting list. So where the hubs have been very good is with the sort of new acute admissions, dealing with them, stopping them going on to the waiting list, and at the same time pulling some of the people off the waiting list as well. So, you know, it's working in two ways to do things as well. This is the key with the surgical hubs, is to move some of the surgery from one place to another where it's doing the high volumes that it needs to do. We know that, for example, when a theatrelist like in a hub is maybe doing hernias and that's all they do in the day, they can maybe do 6, 7, whereas maybe in a standard theatre they can't do that because there's a mixed bag of stuff. They may be doing a hernia, a gallbladder, something like that. So the idea is to move as much of that work into those really focused streams with staff that can just go through as many cases as possible in a day. And probably one of the big things that we have talked about already, and there are sort of negatives to it and potential detriments to it as well, is extending the day and having longer operating days to get through as much of that work as possible and bring in some of that stuff that's been on the waiting list.
In order to do that, do we need more elective hubs?
If this is the simple answer, yes, because we will have to deliver more and more elective care. And I think what you have to realise is surgery and medicine are changing. You know, when we think about hospitals, we think about a model that existed 30 years ago. Medicine's completely different. Surgery's completely different. It has moved on. We need to move with the times. We need to move with how things are changing. And being able to deliver work like that in surgical hubs is part of the answer. It's being able to say, we now have a centre that you're not going to go to a hospital where they're doing a mixed bag of different practice. You're actually going to go to a centre that maybe has a theatre that does hernias 6 days a week, another theatre that does gallbladders 6 days a week.
Right, so that I mean, I think that gives us sort of another interesting scenario. So no surgeon is wanting to go to do only one thing and stay in one place and do. So surgeons are going to have to move around in order to maximise our capacity and efficiency, as you talk about in the health service. But just this morning when we were here, we talked about the difficulties in governance around that. And I do think that was something that we picked up on, and given that we're in a trust building and there are members of the trust here, it'd be really interesting to see what work can be done to ensure that you have the freedom to move around, the legal governance and structures to enable you to do that, so that we can get the best out of the theatres that are here, that are sometimes not operational and could be operational, in the SWA, where some of them have never been commissioned. And it'll be important to do that, and I think that is a piece of work that maybe the committee will continue to press the department on, around those structures as to how you are enabled legally, safely, and within the correct
Well, Mark works
system to do it?
between different trusts.
I believe them solutions are already there, perhaps just not known about widely enough. So, as Niall said, I've worked cross-trust since 2017, and many of my colleagues across trusts in urology do elective work in the Lagan Valley hub, and so are enabled to do that. And our patients move across trusts, and we've had lots of conversations on joint waiting lists and we operate on people from other trusts' waiting lists. So the model is there, perhaps just not widely recognised enough how you set that up. Niall touched on Encompass being an opportunity on that. If you, at the minute, and prior to Encompass, you were moving patients from one waiting list across to another waiting list in different trusts, whereas now you'll go on to an Encompass waiting list and you can select your sites and trusts within that waiting list, and you can amend it and change it within the same case request. I was just going to touch on robotics on one of your questions there. So one of the key things in sort of maximising that efficiency is embracing early things that result in shorter lengths of stay.
Yeah.
And in not embracing early robotics across specialties, we've left ourselves in a position where we're back at lengths of stay which are historic in many centres across, say, in England, Scotland and Wales, where they have already cross-specialty access to the robot, where they're managing the same procedures as overnight stays. If we look at the prostate cancer story before robotics in Northern Ireland, we were only offering open radical prostatectomy, and that would have been a length of stay of a number of nights, and that went down to one night only. So you create efficiency by embracing technology and advancements in surgery, and we need to be early in embracing new technology, so that we can develop and breed that efficiency within our surgical services.
Thank you.
Okay,
And
thanks,
in
Niall.
further sort of response to your question about working between trusts, I was a consultant in England for 6 years, and my week involved me working in 3 different trusts, and I just moved seamlessly between them. So it is possible.
Okay. Thank you. Orlia?
That's sorted.
Yes, thanks very much, Niall and Mark. So I just want to go back to the issue of the census, and I know that you briefed the committee on this previously. It must have been whenever the January 24 census was maybe just published, and you give us that figure around 91% of consultants over the age 55 intending to retire in the next 4 years. And I'm just conscious that we're a year on. As you said now, you maybe can't judge how those figures sit today, but you'll find out if you do another census for 25, 26. But we're a year on, so potentially we could be in the space where those 91% of surgeons in that age bracket are still intending on retiring. So we could be facing that cliff edge in 3 years' time. So Nuala had asked the question around it, and I just want to pick up on it again. In terms of the department and what focus has been put on that issue to address that, because it's extremely serious. And you had mentioned earlier now that we can be very reactionary at times in dealing with things and in responding to things. And for me, that 91% of surgeons potentially leaving the system in 3 years' time, it can't get any more urgent than that. So has the department formally responded? Are they working with you in any sort of coherent or structured way to try and address that particular issue?
I think the department are certainly, because this is not just isolated to surgery, this is all of medicine as all. I think there are a lot of things that are outside of their control. There are certain pension changes that have resulted in how long surgeons, doctors in general want to work, where it becomes to a point that it's almost financially inviable for you to continue working. So I think that's outside of their control. Yes, they've engaged, because what we've now developed is an actual process to allow partial retirements. And partial retirements, and briefly, is that you retire but you come back and you do almost half the work or whatever that you were doing before. And a lot of those people, I certainly have 2 consultants that would otherwise have just left, but they've decided this system is in place, I can now do a partial retirement, so I will continue to stay. They are very important to departments. A lot of them do a lot of the teaching. A lot of them are very good at doing the rather complex cases, and more importantly, it is that sort of progression, because what you're able to do with them is you can bring somebody else into the department because there is now funding available, because you're no longer paying somebody full time to be there. They're coming in and they're able to train them, supervise them, support them, mentor them. So there are a lot of positives to that as well. How will it change from that? I think there will be. But a lot of it comes back down to as well, it's not just retirements and pensions and stuff like this. It's, you know, people getting to a certain age, 60 years of age, where we've talked about, you know, 60% are burnt out and stressed, 50% feel that there are system challenges that prevent them from doing their day's work. When you change those and focus on those as well, you get people that want to stay in their job. And I think it's very important that those types of things that Diane has just talked about as well is the amount of time that a surgeon's spending operating. If you increase that, you again give people, they feel autonomous, they feel that they're valued, they want to stay on their jobs.
Yeah, and because I suppose you had mentioned also, Mark, around the brain drain with the robotics, but we could have all of the surgical hubs in the world in every part of the north. If we haven't got the surgeons and the consultants to staff them, to train, as you say, as the junior doctors coming through, it's pointless. So, and I know Diane had touched on that issue of theatre capacity as well, and utilised and had a discussion with some of the staff in Daisy Hill earlier on this issue as well, how you can maximise the use of your staff and your surgeons and your consultants and your nursing staff. And so, again, although you had says the biggest barrier at the minute would be not having the staff and resource. I think Diane mentioned there is unused theatres in the South West Acute Hospital, and there is a significant number of unused beds there. So given that space and location is sort of sitting there unused, and that's obviously public knowledge, in the interim of the staff crisis that we're facing, would there be any solutions that you could provide, or any options that you could think of where you could actually make use of that space with the staff that we have, or is there just too much pressure on people currently?
I think if the access was offered, it probably would be taken up. There are, yes, certain challenges, and one of the things would be brought up by our sort of members, and I think Mark has already touched on it as well, is, you know, there is difficulties with travel. Now, we know that about 80% of people are happy to travel to have their surgery somewhere else. Some of that is based around the fact that there is a continuity of care. We do know that through GIRFT and stuff, that where a patient has seen a surgeon, they are increasingly unlikely to go somewhere else to be operated on by somebody else that they've never met. So we would have to address those things as well. One of the issues, obviously, when you talk about the location of hubs and stuff, is, you know, the time problems there. Is it really a good use of a surgeon's time to spend 4 hours travelling up and down to a surgical hub? But it's about moving staff round. I think what Mark touched on as well is, you know, people in different times of their careers, there may be that, you know, senior people are quite happy to travel and spend time in other places. More juniors may not be able to. But I think overall, we certainly need an expansion in staff, and be that at consultant level as well. We need an expansion in our trainees, and we need an expansion in the staff, the staff, the surgical hubs. But if those were on offer, then yes, certainly those facilities could be utilised more.
Okay, thanks for that. And just finally, I am a Belfast representative and a Belfast service user of Belfast Trust, but this is my first visit out today to the Daisy Hill Hospital, and just it's been fantastic, I have to say, and just in particular around their elective overnight stay centre that they have, and obviously that's one of the big pitches that you're making today, that we need more of those, and they are a case in point in terms of, because they've been able to take on more procedures, additional procedures, that's actually helping train the additional junior doctors and staff that's coming through. So it proves the point that you were making earlier, Niall, just in terms of the importance of expanding the surgical hubs, and then, you know, how helpful that will be and beneficial in terms of training. So thank you, Chair.
Sorry, I was just going to come in on just one answer on the retirees. There is probably some other things, and I think, Diane, someone described it as scratching at the edges with the hubs, but there's another little thing that Niall described, how he's had two colleagues partially retire and come back, and that's great, and that worked within his specialty. But within some other specialties, they can be left with a challenge where someone's retired but wants to come back, but they need to fill the post that they previously held because they have to fill the on-call rota and cover emergencies. And in filling that post, they no longer have any funding to pay the retire and come back person. And so what we could do is look at some means of providing finance for that short-term part-time working for them retire and come back consultants. Trusts and specialties are commissioned to a number of consultants, and it's once they're full, they're struggling then to find the money to commit to a salary for someone for that part-time salary.
No, thank you. Well, that's a helpful solution. Thank you very much, Mark.
Thank you. Alan?
Yeah, thank you, Chair. Across the overall surgical workforce, is there an imbalance in the number of, say, anaesthetists, surgeons and theatre nursing staff? I'm thinking, for instance, a surgeon may be frustrated from carrying out a procedure because he doesn't have the availability of an anaesthetist or the theatre nursing staff. But equally, could an anaesthetist and a team of nursing staff be frustrated in carrying out or going ahead with a procedure because the surgeon isn't available? So is there that imbalance? And the second question is, I know this wouldn't be an issue in the hub situation, but over recent weeks we've seen how the flow through EDs have been impacted by the lack of beds. Is the elective, can your elective surgery work be impacted by the availability of beds? You know, can that have a negative impact on the procedures that you want to carry out, that there's not a bed available at the other end?
In answer to the first part of your question, I don't think that there's necessarily an imbalance of staff. I think that there are staff shortages everywhere, and you know, so keeping it sort of quite simple to is, you know, you may have surgeons that work in various specialties and deliver various types of surgery and operations stuff. The anaesthetists that they might work with might work across different specialties as well, so they may not be available all of the time. So we do have this, that where, you know, there may be a rate limiting factor in a day of the number of anaesthetists that are available to do lists within the whole of the operating suite. So say you have 10 theatres but you've only 8 anaesthetists, well, you can only run 8 theatres. So you may, if you have 10 surgeons, well, 2 are not going to have anybody. We are seeing sort of a lot of changes so within some of the hubs and stuff, with, you know, having to shift over more and more sort of local anaesthetic to try to reduce down the number of general anaesthetic lists as well. That's a very positive thing, but it also means that in times that some of those lists are not being covered by anaesthetists. So, I mean, one specialty had, I think it was 6 lists before COVID. After COVID went down to 3, and they're now down to 1.25. And in fact, they've now just lost the anaesthetist for that. So that's a massive drop down. And again, that's back to a shortage of staffing. In terms of, does unscheduled care affect elective care? Yes, it does, because we do cancel cases. We try our best not to, and we work very hard with patient flow between the surgeons, the ward staff, all of this. Try not to, but there are times where surgeries, including cancer surgeries, get cancelled because there's no beds.
It's very dependent upon the site. So your Lagan Valley in Oma managed without an issue. I mentioned Belfast City Hospital, we're not impacted. But move into Niall's World in Royal Victoria Hospital, you're going to get impacted greater for the if you move to the inpatient care in Craigavon, in the Ulster Hospital, in Antrim, in Altnagalvin, you'll find exactly the same, because the emergency pressures are felt on them sites.
So that could have an impact on, you were saying there earlier about surgeons are only like 30% of their time is actually spent in the theatre. So that could be a contributory factor, the fact that there's not the availability of a bed for a patient coming out of the theatre into recovery.
The 20 to 30% calculation that we do though is based basically on what's called a job plan. So it's looking at the amount of time in a week, in your normal working week, that you are scheduled to be in a theatre. But yes, it goes down even more when you get cancellations. I worked in England. I worked in a standalone cardiothoracic hospital. That's all we did. There was no ED, nothing attached to it. I could probably count on one finger the number of times I had a cancellation in 6 years because of a bed issue.
Okay, thank you.
Thanks, Alan. And Colin.
Thank you, Chair. Apologies for missing your presentation. It would appear the only thing more scarce than a National Health Service appointment is a parking space in Newry, so apologies for that. And sometimes we come along to these meetings and we hear an awful lot because they're long meetings and there's lots of presentations, and sometimes you have to just shake yourself whenever you think, did I just hear that right? And actually you have to write things down. But having surgeons that only do surgery 20%, 30% of the time is scandalous. Michael O'Leary would not employ pilots and then put them flying 20% of the time and say, we don't have airplanes, or we may not have cabin crew, or we may not have other stuff. But we've got a health service that I would think if it was 20% short of their time, so if they were only 80% doing their amount of surgery that they should, that would be a scandal. But we have a health service that has let people down for a generation in terms of workforce planning, that they can only perform 20% of the time, and then at the same time we all look around and go, wonder why we've got such long waiting lists if we can't get people into surgeries. My question for you is, what is it frustrates you most about your job? And I think that's probably the answer, but what is it that frustrates you about with our health service that most in terms of doing your job?
I'm very pleased with your analogy, Colin, because I say exactly the same thing. And I use Michael O'Leary as well. It's as if he came in and looked at it. Yeah, you don't have pilots sitting twiddling their thumbs. Mm-hmm. They're flying the planes for all their hours. They're not doing any other work. We know that through our census that one of the things that is upsetting to 50% of surgeons, and that's from consultants down to trainees, is I'm not getting into theatre to do the job I want to do. Mm-hmm. This is a job I have devoted my life to. I have spent, on average, around 14 years, to become a consultant, learning to do. There have been multitude of sacrifices along the way, both, professional and personal, to get to that level, and here I am, not able to do the job that I want to do. That is what is causing massive dissatisfaction. Now, we do know that across the UK, the amount of time used to be that surgeons would spend 2 days a week operating. A lot of the time that has come down a bit, and that's because they're pulled more to different things now as well. But it is, if there's one single thing that causes frustration, it's not being able to do your job, because that then builds in seeing patients in an outpatient setting and saying, I've seen this patient, I know I can do something to improve their quality of life, to remove some of that disease, but I'm not being given the opportunity to do that. I'm putting them onto a waiting list, knowing that waiting list could be anywhere between months and years, and in some cases almost up to a decade.
Can I ask, are you aware, is there a recovery plan within the department? Has the department actively got a plan to address the specific issue of how a surgeon can perform more surgery? Is there a specific detailed plan that has been worked to, or are you just subjected to a series of, there's a workforce plan here and there's a hospital plan there and or is there a dedicated plan by the department to address the specific issue?
I'm not aware of any dedicated plan to do it, but again, it's one of these things is you can't necessarily just take it in isolation. It's about infrastructure, the number of theatres available in a hospital. It's about ward beds. It's about, nurses for the theatres. It's about equipment, robots, attracting people, all of that. So it's not that you could just turn around and go, right, we're going to increase everyone up to 50%. there are a multitude of other things that cross-cut it.
There's also the impact of, and I've touched on, vacancies in a rota. If you've got a specialty with a heavy emergency surgical requirement, say general surgery, and you've got vacancies in the consultant rota, in covering them gaps that they have to cover, you're inevitably reducing the amount of theatres that are there. So Michael O'Leary may be a good example, but the 80% may not be realistically achievable, because the surgeons in some specialties where they have acute care do have to deliver that as well. So
I'd say he'd get it working. I'd say he'd get it up higher.
But getting up to that 2 days a week, which I would have experienced when I was a consultant in England, absolutely.
Well, I hope certainly that as a follow-up this, it will write to the department, and it would certainly propose that, find out what they're doing, and are they aware of this, and are they addressing it, what measures they're doing to address it, because if they're not, then we're missing the point. Thank you, Chair.
Okay, thank you. Danny, just for a final quick point, and then we'll...
Sorry, Niall, you had mentioned about patients travelling. It's my experience that most patients I talk to would love to travel anywhere. They'd be very happy to do that and very happy to take any surgeon. Are surgeons happy to travel, and would they be happy to work on with other surgeons' patients?
In general, yes. I mean, they are happy to do it. I think one of the things that people do forget a little about in some of this is the practice of medicine itself. When you see a patient and you're offering them surgery, there's an unwritten contract almost between you and the patient. And I think a lot of patients don't like it, and some surgeons don't like it, in that the fact that they've seen a patient, they're going to take them through the whole journey, whereas some patients would feel that, well, I saw this surgeon and now somebody else is operating on me and I'm being followed up by somebody else. I'm not keen on that, and we know that through the GIRFT as well. One of the things that they started doing was ensuring that it was the same person and reducing travel. So what they did was say, well, what you will be doing is you will be seen at your local hospital for your pre-assessment. Your surgery could be 50, 60 miles away at a different hospital, but your review will, again, be back at your local hospital, and the buy-in from patients there was fine. One project they ran was they got taxis as well for patients that were having to travel, and the consensus was, I think this was in and around South East England or London, can't remember exactly where it was, but they offered this to patients. 16 patients asked them to provide them with transport. That was out of 800 patients that travelled to a hub.
So patients very happy to travel.
More than happy.
On the surgeon travel side, Niall's touched on the points in careers. So when you've got, say, a young family, you've got childcare needs. I remember living and working in Sheffield, and the sort of screeching into the nursery car park with the children sitting on the edge of the path. Now that wouldn't work if you're travelling to a hub that's an hour and a half, 2 hours away from where you live. So you have to, I think you have to consider what's a manageable, deliverable work-life balance for the surgeons as well. Not expect a surgeon to be in one hospital on Monday, a different hospital on Tuesday, another one on Wednesday, and spending a lot of time in their cars travelling.
And working on other surgeons' patients is...
So it's interesting. So Niall's touched on an aspect of it. So quality of life functional surgery is which a lot of the high volume, low complexity work is. That's possibly a bit more important than, say, the big cancer surgery, say, taking out a kidney cancer. That's pretty much the same expectation across the team that deliver that. But managing some urinary incontinence with functional expectations and nuances in there, is that surgeon-patient relationship may be a bit more important.
But in general, we would pull patients because we know that where we do have service delivery problems and delays, particularly in cancer surgery, a lot of patients will be pulled to say, well, this patient has waited for a certain period of time, they're next on the list, whilst it might be the surgeon that has seen them could be off on leave for 2 weeks. It's not appropriate to have them wait for 2 weeks, so they will be operated on by somebody else. And in general, I would say probably less than 10% of patients would ever turn around and say, no, I would prefer to wait. The vast majority are quite happy.
We certainly pool in my specialty in our cancer surgery without any issue from patients.
Thank you very much.
Okay. Look, thank you, Niall and Mark. I think that was a really informative session, I suppose, given that we had heard so much on, I suppose, on the ground this morning. It was really good to get a lot of that feedback. So we appreciate you coming back, committee, and thank you for your time. Okay.
Thank you for having us.
No problem, thank you. Members, just I suppose to give a few minutes as we change over now for the next session, just again to remind people if we can keep our voices quite loud, as loud as possible and clear. It's particularly where I am, it's hard sometimes to hear people further down the room. And I know it's quite warm in this room too, so we need to keep the air on.
No, you're not soft voice. Maybe it's just yourself.
Swing by the supermarket tonight.
I'm just thinking of it. It just hasn't been.
Okay, members, thank you everyone for your patience. We did run a wee bit over time there, so appreciate that. Item number 6 then is the oral briefing on the Cervical Cytology Screening Review. In attendance today we have representatives from Department of Health, Public Health Agency and the Southern Trust. If we could just refer members to the written briefing from the Department at page 96 of your pack and background papers from page 103. So I'd like to welcome Colm McCafferty, Acting Chief Executive of the Southern Trust, Stephen Austin, Medical Director of Southern Trust, Joanne McClean, Director of Public Health for the Public Health Agency, Tracey Owen, Deputy Director of Public Health for the Public Health Agency, and Siobhan Broderick, Director of Population Health from the Department of Health. You're all very welcome, and thank you as well for waiting. And just I want to pay a tribute to some of the women who are also in attendance here who are actually impacted by the review. So thank you for your attendance as well today. We really do welcome that. Members, we have about an hour for this session. I know people will have lots of questions, and I suppose to remind that we try and keep questions and responses brief so that we can get through as much as possible, and that everyone gets a fair opportunity to do that. The session will be covered by Hansard. If I could invite the officials to make their opening remarks, and I'll open up to members. So thank you. Okay.
Thank you, Chair. First of all, I want to thank the committee for agreeing to conduct their business here in Newry this afternoon. Obviously, the topic of a conversation across, different site visits and so forth this morning, but your presence here is important to the local community, particularly adjacent to Daisy Hill Hospital. I also want to thank members for taking the time this morning to visit a number of key sites on the Daisy Hill Hospital, for engaging with staff, to hear about the very real pressures being experienced within health and indeed social care at the moment, but also to facilitate conversations around ideas, around service developments, and hearing about potential in terms of how we are doing things differently, but more importantly, how we can upscale that and do many, many more things differently as we move forward. I do believe those type of conversations are helpful. Those type of conversations are really important in terms of enabling ideas of service development and so forth to get traction for the betterment of services as we move forward. Also want to thank the committee for inviting members of the Southern Trust and other key agencies to provide an update with regards to the Cervical Cytology Review, and particularly in relation to information updates following the publication of the review report earlier last month. It's important to note there's considerable focus on the review, where there's been deficits, how the callback involving 17,425 women has progressed. This focus is entirely correct, and I would also suggest essential in terms of building trust in the process, in terms of confidence and ensuring total transparency, which this trust is entirely and completely committed to throughout this entire process. From the outset, on behalf of the Trust, I want to again sincerely apologise to every single woman who has been impacted upon this. By virtue of being involved in a look back or a callback exercise, even where thankfully the vast majority of reviews were normal, the anxiety, distress and uncertainty created by that, again, I need to apologise for on behalf of the Trust. I'm also aware that there's a small number of reviews which identified our abnormalities, and that there's a small number of women who are since in receipt of treatment and intervention. I want to reiterate the Trust's total commitment to ensuring that those women receive the best possible support, intervention and care that's available. The Trust fully acknowledges that there have been failings and difficulties within the screening process, as clearly identified, and indeed as much commentary with regards to. We are entirely committed to learning from any of those failings, entirely committed to implementing any recommendations coming from the reports that we're going to discuss today, or indeed any other reports thereafter, with a view to improving services, not just with regards to cervical screening, but if there's any relevance to any other elements of Trust services, we're wholly committed to ensuring implementation of that. So I'd now like to introduce colleagues who will provide updated information this afternoon. Siobhan Broderick, Director of Population Health, will speak briefly on the roles and responsibilities in terms of cervical screening programme. Dr. Stephen Austin, the Trust Medical Director, will then provide background information and findings of the Cervical Cytology Review. And finally, Dr. Tracey Owen, Deputy Director of the Public Health Agency, will then give an overview of the Northern Ireland Cervical Screening Programme, details of the confirmed cancers reported within the Trust during the period covered by the review, and the next steps. So, if committee's in agreement, I'll hand over to Siobhan now.
Thank you, Colm.
So, thank you for the invite to come today. And as Colm has said, I want to set out the roles and responsibilities across the cervical screening programme. So, in relation to policy decisions, the Department is guided by the UK National Screening Committee. This is an independent committee that advises the ministers and the health services across the 4 UK countries about all aspects of screening. It makes evidence-based recommendations about whether to introduce, continue, change or withdraw screening programmes for a variety of conditions. In addition, we have the Northern Ireland Screening Committee, which considers the recommendations that come from the UK National Screening Committee and is chaired by our Chief Medical Officer. The Northern Ireland Screening Committee provides policy advice to the Minister of Health with a specific focus on implementation in Northern Ireland. It is the Health Minister who considers and decides on the screening policy in Northern Ireland based on the advice of the two committees I've just mentioned. The Northern Ireland Cervical Screening Programme encompasses a range of services by trusts, GPs and the Business Services Organisation. In terms of roles and responsibilities as pertain to the delivery of the Cervical Screening Programme, the main stakeholders are the Strategic Planning and Performance Group, SPPG, you're familiar with within the Department, the Trusts and the Public Health Agency. SPPG is responsible for planning, commissioning, improving and overseeing the delivery of effective, high-quality, safe health and social care services. SPPG commissions services provided by trusts and GPs across Northern Ireland. The SPPG is part of the department, as you know, and is responsible then directly to the Minister. Each trust is responsible for the delivery of services, which include lab services and diagnostic services, which sit within the gynae services. trusts have a statutory duty of quality for the services they provide, and trusts are accountable to the department. The Public Health Agency provides oversight and external quality assurance of the Northern Ireland Cervical Screening Programme, to include the provision of lab testing, and the PHA as an arm's length body is accountable to the department. Finally, in terms of governance and oversight, at a trust level, internal quality controls occurs in line with the NHS Cervical Screening Programme recommendations. The performance of all screeners is actively monitored and managed by the trust. At a regional level, the PHA reviews all key performance data associated with the screening labs and discusses any deviation from a standard in detail and within the context of all data and mitigating factors at annual data review meetings with each trust. Within the department, the screening policy branch has regular contact with PHA and receive date updates on all screening programmes. In response to the RC Path report, which we're going to discuss, into cervical screening in the Southern Trust, the department established the Cervical Screening Oversight and Assurance Group in November 2023, for which I think we've shared with you the terms of reference, should be in your pack, and to receive assurances in respect of the Northern Ireland Cervical Screening Programme, and in particular, the full implementation of the primary HPV screening pathway, implementation of the RC Path recommendations relating to the Southern Trust, and maintaining and building on the public confidence in the cervical screening programme in Northern Ireland. So the Cervical Screening Oversight and Assurance Group is co-chaired by the Deputy Chief Medical Officer, Lurda Kagan, and Peter Toogood, who's a Grade 3 within the department. It initially met weekly after it was established in November and now meets monthly. Its membership includes the PHA, SPPG, Digital Healthcare NI, the Chief Medical Officer, and senior colleagues from across the departments. So I'm going to pass you over to colleagues in the Trust and PHA.
Okay, go ahead, Stephen.
Thank you again very much for the invitation to meet with you today and to share information on the update on the cervical screening review. The Southern Trust provided cervical cytology laboratory service until October 2023 as part of the Northern Ireland Cervical Screening Programme, and this was initially commissioned by the Public Health Agency. From its outset, it's important that again we apologise again to the women and their families impacted by the failures in the cervical cytology service in the period 2008 to 2021, and we are sincerely sorry for all the hurt and distress that people have suffered. It is, of course, important to remember that it's vital to reassure women that Northern Ireland's cervical screening programme is highly effective, and people should still come forward for that. Cervical screening, and cytology in particular, is a qualitative test undertaken in a laboratory setting by biomedical scientists who examine the cervical smear tests or slides under a microscope for 8 minutes. It's not a diagnostic test. It does not and cannot identify all women at risk of identifying cervical cancer, but the screening programme looks for precancerous changes in the cervix which, without treatment, could develop into cervical cancer. Whilst the programme is highly successful, it does have limitations and is only able to detect approximately 3 out of every 4 abnormalities. Obviously, we have the new introduction of HPV test in December 23, which is a welcome development, as it's a much better test. So what went wrong in the Trust? Well, the performance of any screener can dip from time to time for a range of reasons. There are systems in place to pick this up, and screeners are given annual skills training to keep their skills up to date. During the period 2008 to 2021, some screeners' performance in Southern Trust Cervical Laboratory did fall below the recognised standard. The underperformance was identified by the Trust at the time, and actions were taken to deliver improvement. However, the performance of some of those screeners did not reach the required standard for a number of consecutive years, and this was not recognised. We fully accept that the actions of the Trust at that time were not sufficiently robust. In July 2022, senior laboratory staff notified the Trust's senior management team that they had concerns about the performance on some steps of the laboratory screening system. To fully investigate those concerns, the Trust commissioned the Royal College Pathologists Consulting, RC Path Consulting, to undertake an independent assessment of the cervical screening services for the period 1st of January 2008 to October 2021. The Royal College of Pathologists, I'm just going to the first slide here, made a number of recommendations for the Trust and the PHA to improve the governance. And just to briefly mention these, the first one was to introduce measures to ensure that all cytology staff, all grades, who do screening, reporting and checking, achieve the minimum workload standards, so they're doing enough work as required. The second one was that there was a safe, sustainable approach to staffing in the laboratory that matches the workload, so that avoiding people doing too much work and no overtime. Recommendation 3, and this is crucial, that all persistent underperformance is actively managed appropriately and promptly. And number 4, the management of the potential screen underperformance policy was then appropriately updated, and if there's any deviation from that would be fully documented to the required standards. And the next slide. Number 5, that the standards of performance for monitoring deviated in any way, that the appropriate derogations were documented in trust policy if they were to occur. Number 6, that there were adequate resources and full compliance with all the procedures of the cervical screening programme, cancer audit programme in the review, and there was full disclosure in line with the audit protocol and women's wishes. Number 7 basically called for the implementation of primary HPV screening, which you'll hear more about in a few minutes. And number 8 was about basically undertaking the cervical cytology review, which we undertook in more detail. So in October 2023, the Southern Trust, in partnership with the Public Health Agency, introduced a precautionary review of cervical screening results of 17,425 women, thank you, Tracey, screened between 2008 and 21. This was a precautionary measure to check these women's slides and reduce the risk of those women developing cervical cancer and those who may have had an incorrect result. The review was completed, and there were 2 key reports published in December 24 by the Trust and PHA. The first report dealt with the factual details and findings of the cervical cytology review, and the second report focused on cervical cancers in Southern Trust area and across Northern Ireland, and you'll hear a bit more about the second report from my colleagues in the PHA. The review identified that the vast majority of women, and that's 96% of women, of previous smear results have been reconfirmed as normal. In the total review of all the women, there were 11 women whose slides were found to have precancerous or incidental changes when they were reviewed and had to receive treatment. The treatment for those women has either completed or is still in progression at present. The findings of the second report showed that there were 12 women who were diagnosed with invasive cervical cancer in the Trust during this time period from 2008 to 2021. They would have been included in the review if they had not had cervical cancer, but they underwent a review in the audit of invasive cervical cancer. Concerns about the accuracy of screening of the original screening result on these cases, 8 of them there were concerns out of the 12. All the findings were and are currently subject to an independent expert panel review, which we'll hear a bit more in due course. That's the findings of the cervical cytology review. As I mentioned previously, in December 23, Northern Ireland introduced the primary HPV screening, which tests for the presence of human papillomavirus, HPV, which is responsible for almost all cases of cervical cancer. Since November 2024, Belfast Trust has taken over the screening for cervical cytology, and none is done within Southern Trust at present and hasn't been since 2023. The failings in the lab extended beyond individual staff members and reflected wider system failings and policies dealing with poor performance. Without doubt, these were below the required standard. Whilst the screening performance was recorded during these years, it was not assessed from year to year to look for patterns. It only when new staff came into the lab that issues were identified and concerns raised. We recognised this was a completely unacceptable breach of governance procedures and did represent a system failure. The Royal College Pathologist report produced governance recommendations for both the PHA and the Trust, aiming to ensure these governance failures wouldn't happen again, and all these recommendations have been implemented in full. In terms of why the wider system did not pick up these failures at an earlier stage, this will be examined by the independent review expert opinion of the cervical cytology review, and there's a wider review that you'll hear about from PHA colleagues in a few minutes. The screeners identified by these failings are no longer working as cervical cytology screeners and haven't been doing this work since 2021. We appreciate and share the frustration that many have experienced in terms of understanding how these historical failings in the Trust Lab could have happened and spanned over the 13-year period, extending as far back as 2008. It has been challenging for the majority of staff who worked in that time are no longer there, and very few of the management team in that period are still in post. But it's important to note that we have not provided cervical cytology for well over a year in that service, and the service has moved centrally. Whilst the whole situation has been totally unacceptable, I do want to include a positive note in that with the introduction of the new HPV screening, that is a very positive benefit for women with a much superior test. And it's important that, again, just remind women that they do need to to attend for smear tests as normal, because it is extremely important to do so. I'd like to hand over to my colleagues in the PHA to give you a further final update.
Thank you, Stephen. Okay, thank you for the opportunity to meet with you today and provide you with an update on cervical screening. Firstly, I want to acknowledge the impact of this issue and the review has had on all the women and their families involved. We really recognise the distress, the anxiety that this has caused. We understand that and we want to apologise for it. Screening programmes are aimed at populations, and I'm going to be talking today about some data and statistics. But each of us who has lost a loved one to cancer in the past knows that behind every piece of statistics is an individual person, a family, and those with personal stories to tell. We're very mindful of that, and we fully understand that. But it is important that we consider that wider context of cervical screening relating to the population so that we have the full picture. So the second part of the review, we have the activity and outcomes report, and then we had a companion report which looked at the cervical cancers in the Southern Trust over the time period involved. There was two main sources of the data that we looked at. The first one was the Northern Ireland Cancer Registry data. The Northern Ireland Cancer Registry is a very recognised, trusted source and reliable source of cancer data, all cancer data in Northern Ireland. It provides us with comparative data that we can compare trusts. We can compare Northern Ireland with the rest of the UK, and we can compare Northern Ireland globally across Europe and elsewhere. And they can adjust their data to recognise that, so we are comparing like populations with other like populations. The Northern Ireland Cancer Registry reports that there's an average of 81 cervical cancers diagnosed in Northern Ireland each year, and an average of 14 of those are in the Southern Trust area. When they looked at the incidence of cervical cancer, what they found was that the incidence of cervical cancer in Northern Ireland is very similar to the rest of the UK. And in fact, Northern Ireland is probably a bit lower incidence of cervical cancer than England and Scotland and Wales. The Cancer Registry was able to do some comparative data analysis for us. And what they found was that the number of cervical cancers, the stage at which cervical cancers are diagnosed, the mortality or the death rate from cervical cancer, and the rate of precancerous cervical changes that are diagnosed in the Southern Trust are not significantly different compared to the average in Northern Ireland. So Southern Trust is very much in line with what we see across the rest of Northern Ireland. We also looked at the data we have from the audit of invasive cancers, and the audit of invasive cancers is where we look at all women who are diagnosed with cervical cancer. There is an audit of her screening history. The purpose of that is for learning and for education, and it involves a review of all the contacts she would have had with the screening programme in the 10 years prior to that diagnosis. So it looks back at the invites that she received. So did she get invited in the first place for screening, as she should have? Do any screening samples that she had, they do get reviewed. And any colposcopy, further investigations or treatment that she may have had, that lady may have had in that 10 years. So it's a complete review of her whole screening history. And Southern Trust, when we looked at the cancers that were diagnosed in the Southern Trust between 2009 and 2023, there was 207 women had been diagnosed with cervical cancer in that time period. These women were not included in the CCR because under the audit process there was a much more in-depth review of their individual cases than what the CCR was doing in terms of just a look back and a review of their current or most recent screening test. This graph just shows the cervical cancers diagnosed by year. As I said at the beginning, we have an average of 14 diagnosed each year in the Southern Trust, but it does fluctuate year by year, and that's a normal pattern when we've got small numbers. But it gives you an idea of what we do see. We also tried to see if we could compare any data from the audit that we have from the Southern Trust with published data elsewhere. So England do publish quite significant reports on their audit, and we were able to do some comparative data just to tell us if there were any real obvious differences in the women that we have in Northern Ireland or in the Southern Trust who were developing cancer. And this table shows a breakdown of the type of cervical cancer. So the most common type of cervical cancer is a squamous cell carcinoma, and that's the cancer that occurs in the cells that line the cervix. And it makes up the vast majority. And you can see 65% in England, 69% in the Southern Trust. So they are very similar numbers is what we were seeing. Adenocarcinomas are the second most common. They are more rare, and they're glandular type of cancer that occurs at the top of the cervix as the cervix enters into the room. They're much more rare cancer, but we do know there's lots of evidence to show that adenocarcinomas are much more difficult to pick up at screening, and often they're the difficult ones that turn up later on. We also looked at the screening history of those ladies who were diagnosed with cancer, and those who were up to date with their screening history, and women aged 25 to 49 get invited every 3 years for screening. Those aged 50 to 64 get invited every 5 years for screening. And England have reported on this in the past that 20%, which is 1 in 5 women aged 25 to 49 who were diagnosed with cervical cancer had actually had a negative screening test reported in the 3.5 years prior to their diagnosis. And for women aged 50 to 64, 27%, so over 1 in 4, had a negative screening result in the previous 5.5 years. So we looked at the Southern Trust figures, and although just very cautious that the numbers we have are much smaller, when in England they're talking about thousands of women, we're talking about smaller numbers of women, but you can see the comparative data is very, very similar to what England report as well. We looked at those cancers and took an assumption that if those ladies had not been diagnosed with cancer at that time, would they have been included in the cervical cancer review, cervical cytology review undertaken by the Trust. And of the 207 ladies who were diagnosed with cancer in that time frame, we found that 12 of them would have otherwise met the inclusion for the CCR. And on review of their slides, 8 of them had identified concerns about the accuracy of the screening result in the past. And 5 of those 8 are now subject to further investigation under the Serious Adverse Incident process, which the Southern Trust, Dr. Austin, can talk about in a moment and explain more. We had an additional small number of women, under 5 women, who were diagnosed in other trusts that would have met the inclusion for the CCR as well. And their cases are being further assessed to see if there is anything in addition that needs to be done for those. I just want to point out and explain that reviewing a slide under audit conditions is extremely different to reporting a slide in a screening programme, because the person who's now looking at a slide knows that that woman now has cancer, so it's not blinded as such. They have as much time as they want to review that slide, so the longer you have to look at a slide, you know that lady has cancer, the more chance you have of finding an abnormality there that may not have been afforded to the person who did the primary screening at the time. And it's usually a more senior member of staff who does the audit, and generally tends to be a consultant who looks at those cases. That's not the case in most cases where we're doing screening, and certainly not primary screeners. So it is a very different process, and we do expect that on review and audit there will be abnormalities identified in some slides that were initially reported as negative at the time of screening. And it happens in all cancer cervical screening programmes across the UK. They do find these cases. So what's happening next? There are 3 ongoing pieces of work. The first one is the review. I mentioned the serious adverse incidents and the process. There are a number of women who are now being reviewed under a serious adverse incident process relating to the Southern Trust laboratory, and the Southern Trust can speak a little bit more about that. We have asked for an independent external opinion on the 2 published reports, so the outcomes and activity report and also the cancer report. They're very factual reports. They just give the facts, the figures, the numbers. And what we have asked is for 2 external people to look at those and really, I suppose, give us an opinion of what does this mean? What do these reports mean? What do the statistics that we've now found tell us? The 2 experts, one from Scotland, one from Wales, represent, one is a laboratory expert, one is a public health person, and we anticipate that that work will be completed in February, and we receive a report on that. The other piece of work that we are taking forward is a peer review of our quality assurance arrangements and activities relating to our cervical screening laboratories over this time period. We have approached NHS England. I think you've been given the terms of reference of both of these pieces of work, and we are negotiating with them in terms of a time frame for completion of that work. So we're hopeful it will start shortly, and it's really within NHS England to come back to confirm just the timescale of it. But these are really important additional pieces of work that we have asked for and that we're taking forward, so that we have covered all elements of this review, that if there's any further gaps in our services, in how we have overseen services, in the data that we have, that we can identify if there's any further improvements that we can make going forward. It's been alluded to the changes in the programme, so I'm very briefly going to touch on these. We've talked about primary HPV testing. We had a policy decision by the Minister in March 2020 as part of the Northern Ireland Cancer Strategy to implement primary HPV testing. We set up a project at that point to do that, and it was implemented from the 11th of December 2023. There was a lot of challenges in doing that. It's not something that can happen overnight. We had IT interface challenges. We have quite a significant impact on laboratory services, which I'll come to in a second, and also the impact in terms of increasing referrals through colposcopy, and that they needed then to build capacity in that side of the service for any women coming through the process. If you're not familiar with what HPV is, it's human papillomavirus. It's transmitted by close skin-to-skin contact. It's something that can't be treated. It does usually clear up on its own, and it's a very transient infection that probably about 8 in 10 of us at some point in our lifetime will be infected with this virus. And as I say, most people clear it, but it's when it persists, and it persists in about 20 to 30% of women. They can have it, or their partners can have it for many years without knowing about it. There are over 100 types of HPV, and only a small number of them are directly linked to cervical cancer. And we know that younger women have a higher rate, a prevalence rate of having this infection. 99.7% of cervical cancers are associated with a persistent infection with high-risk types of HPV. And it is about a persistent infection, not infection that most people get and then their body clears it. It can take many, many years between infection and cervical cancer developing. And we've actually been using HPV testing within the cervical screening programme in Northern Ireland since 2013 to help us manage which women should go for colposcopy and further investigation when they have more minor changes in their cells. This is the pathway. So we do an HPV test first. If that is negative, the woman goes back to routine recall now. If it's positive, at that point, then they'll create a slide, looked on the microscope at the slide, and depending on the outcome of that, whether the lady is referred to colposcopy for further investigation. The benefits is, as I say, it's related and linked to over 99% of cervical cancers. It's a much more sensitive test than cytology to determine those women which are most likely to have abnormalities that could go on to develop into cancer. Though it is a bit less specific, so that's why we still need the cytology involved as well, because otherwise we would be referring a lot of women who are HPV positive through to colposcopy that don't need to be there. When comparing the two types of test, an HPV screening test will identify 18 out of 20 abnormalities. That compares to only 15 out of 20 abnormalities that a cytology-based screening programme will identify. So it is a much better test. It's also a more automated test, and because of that, we have a marked reduction in the amount of cytology testing that is now required. Less than 12% of all samples coming into the laboratory are HPV positive and need cytology. So our workload for cytology has dropped from something like 120,000 samples per year to less than 20,000 samples a year. It's a massive reduction in that workload. The decision was made to move to one laboratory for Northern Ireland to consolidate that service. We took forward a commissioning process through an expression of interest out to the laboratories, the trusts, to see who would be interested in delivering that service. And the outcome of that was that the service moved to Belfast Trust from the 1st of November 2024. And there was a lot of work went into that transition process. There was a transition work stream, there was a people work stream, so that all the staff involved were supported through that process. What can screening deliver? It is important, and the National Screening Committee do make this point, that screening is about risk reduction. It isn't about eliminating all risk. No cervical screening programme will provide a 100% guarantee that someone does not have cancer or will not develop cancer. Over 99% of cervical cancers are linked to primary HPV, but there will be a small number of women who develop cancer that don't have HPV. They are rare, and screening using HPV testing will prevent more cancers than screening by cytology, based on the best current evidence globally. Having cervical changes in your cells, or changes in your cervical cells, does not mean that you have cancer or will definitely develop cancer. And many of those cell changes that we saw in the past did disappear by themselves. And that's why HPV testing is a much better determinant of those which are more likely to go on to develop into cancer. It's also important to recognise screening is not suitable for people with symptoms. So anyone who presents with their GP who has symptoms, is concerned about symptoms, really needs to seek medical advice and one-word referral for assessment if that's needed. It's not, a screening test is not appropriate. Finally, I think I just want to touch on participation. There's been a lot of concern around women's confidence in the screening programme, and that what has been going on in the Southern Trust may put women off from attending. We do have some data that covers the period of the review and compares women's attendance at screening over the last couple of years across each of our trusts. And what we actually have seen is that in the period 23-24, our coverage, essentially our attendance, increased across all trusts in that period, and particularly in the Southern Trust. So we actually found that more women were probably coming forward for screening during that period. We've also undertaken an omnibus survey to try and get some direct feedback from women in terms of their experience and attitudes towards screening and what their confidence is in the screening programme. So in November we included questions in an omnibus survey. It was an online panel. It had a sample size of 500 women. We've now gathered their feedback from. And this is just two of the high-level findings so far. We're still working through the analysis of this. But just to point out that when women were asked, have you attended a cervical screening test in the past when you invited? Nearly 13% of women said they had never attended. And when they were asked in future, do you plan to attend? Nearly 12% said no, they didn't. So there is still a large number of women out there who've never attended, who don't want to attend, and our challenge is really about how do we try and encourage women to come forward for a test that is really important for their health. Finally, I just want to say around cervical cancer and the WHO statement around eliminating cervical cancer by the end of the century. And there's a real move and a recognition that there are three pillars to do that. One of them is to really encourage the uptake of cervical screening. One of them is to try and maximise the uptake of HPV vaccination among young people, really, really important element of preventing this cancer. And the other element is to ensure that anyone who does have cancer or has abnormalities get the appropriate treatment and support that they need. So, thank you.
Thank you. Okay, thank you all. And I suppose we'll just move straight into questions. And I mean, certainly, I know I have been pouring through the reports ahead of today's briefing just to get my head around it, because it is very complex, and I understand it can be quite technical at times. So just to try and be clear on what has happened, where we're at now. I suppose just it would be remiss of me not to mention that this is actually Cervical Cancer Awareness Week. And I think it's important to mention, particularly given, I mean, some of the figures we've seen are that some women still do not go for their cervical smear. And I think if any message can come out of this meeting today, it's that really encouraging women to come forward when they receive their letter. And I suppose secondly, it's also to pay tribute to all the women that have been impacted in this review, but particularly those women who have went on to develop cervical cancer, and also I think especially Lindsay Courtney and Erin Harbinson, who sadly passed away, and to acknowledge their families and the hurt and the just huge amount of grief and loss that they've experienced and continue to experience. I think it's so important to acknowledge that today as well. I probably have lots of questions, and I'll try and get through what I would like to ask today as quickly as possible. I suppose for me, and I've read the Royal College of Pathology report, and the one thing I just can't get my head around is that this underperformance was allowed to continue for 13 years. And whilst we have had the review and the report that were published in December, the end of last year, it goes through the detail of what people involved, the process that has happened ever since. But nowhere in that have I seen why that was allowed to continue, why it wasn't picked up, and why it took so long for us to get to where we are here even today. So I suppose in relation to that, I mean, in the briefing we received from the department, it states that performance of all screeners is actively monitored by the Trust, and that external monitoring occurs by the Public Health Agency. I mean, to what extent was that happening from as far back as 2008 when it was clearly identified that there were significant issues? I mean, I think it said that in the Southern Trust there were 4 screeners and none of them were meeting the standards for quite a significant period of time. So I don't know if anyone here today can answer that, but I just would like to really try and get an understanding of that, because I think for many of the women infected, their families, but for the general public, I mean, we've talked about the confidence in the screening process, and it's really good to see that more women, the percentages is increasing of women coming forward. But I want to ensure that people have confidence in this screening process, particularly now the HPV. So if we can get an understanding of that, if possible, as to how that happened for so long that it was never picked up or never actioned.
Should I just start? Maybe just not. Well, when we're looking at the data and looking at the Royal College of Pathology report, what is quite striking, that is striking what you've described, Liz, is that the underperformance was noticed in the individual screeners in a particular year, so say 2009, and the screeners underwent the usual process to improve their performance and so forth. The next year, the performance was still what doesn't seem to have happened is that somebody looked back and said, actually, last year you also underperformed, so they just seem to take it as an isolated event, or the performance is 85% this year, you go in the training programme and do it, and it does appear to us that you didn't have the follow-through to say, actually, that's 2 years in a row, 3 years in a row. So I suppose one of the learning out of it is that it's absolutely essential that not only do you look at something in isolation and avoid a silo approach, but actually look at the entire pattern of the entire history for any particular person to look, see how they're going, are they responding to the measures put in place to improve performance, and if not, you take action at that point. And I think that's what happened whenever the new staff came into the lab, as I mentioned, in around 2022. Staff looked at that, thought, hold on, and then they raised the concerns and alarms with the trust management, and then we've ended up in the review today. But I think it's very much looking at the entire pattern, of course, not just an isolated individual year. So we figure is this year we do this. Actually, it was this year plus that year plus this year, and look at the entire pattern is really, really important to look at that. And I think that's the really significant learning that's come out of this. That doesn't seem to have happened in that period of time. Now, it certainly does now, and going forward in Belfast, it certainly will. But that seems to be the issue. So it was recognised, but the pattern wasn't recognised, that actually you've done this and you didn't improve, and we're here again. And if you didn't improve, you're here again, seems to be missed. And that's the thing that is the most difficult.
And can I ask, Nancy, because I mean, I don't think that's going to give any comfort to any people, anyone that has been impacted. But who is responsible for monitoring that? Because I think in any job there's appraisals, there's review in terms of people's performance in relation to particularly something that is so critical. I mean, this is life-changing for many people. It's life-shattering, actually, for many of the people that have been affected. I mean, in the Royal College's report, they've said for those where the underperformance was identified, there was no evidence of any increased quality control or targeted training for underperformers, no evidence of formal rescreening, no evidence of workload reduction, no evidence of out-of-hours or overtime being discontinued. So it obviously was picked up that those were the key issues. Whether the screeners themselves were voluntarily sharing that information, said that they felt that they were doing too much work, they were doing too much overtime. But at no point did anybody, even if it was the same person doing the review every year, whether it was in silos, did somebody think, hang on, this is ringing a bell? So I suppose I'm trying to understand is, what is the process? Would that have been the proper process that it was looked at in a silo? I know you appreciate you've said there's learning there. Obviously, that's where we are now. But I mean, at that point, would anyone have said, we're actually doing this wrong? We should have been doing it on a year-on-year basis and comparing that year-on-year for screeners.
I suppose one of the difficulties is obviously we were looking back and we're looking back now, and you say the Royal College of Pathologists. With hindsight, it's actually very obvious. When you look at that, and you picked it up, I picked it up, and so on. At the time, obviously we weren't there at the time, back in say 2008. But at the time, the annual appraisal that staff would have looked at the data for that year. But it appears they don't seem to have looked at the broader pattern, as I've mentioned already. So I suppose that's one of the reasons that led to the review that we have done. Now, I suppose it's reassuring to find that the vast majority of the negative results, 96%, were still negative, and there's a very small number of women, important number, still had to go further preventative management and treatment. But I suppose the thing that we have picked up is that you really need to think of the whole picture across the whole cycle, and that's the key learning we've got. So I wasn't back in the time and to understand the thinking at that time, but at that time, one can only presume that they looked at the year in isolation and didn't look across the piece to think actually this year plus the year 2008 plus 2009, 2010. And that's certainly, as you say, the very strong learning that's coming across. And it seems obvious to do that now, but then again, back 15 years ago, I suppose the systems there were different, and now because we're much more attuned to the governance now than we would have been back 15 years ago.
I suppose that's the question I'm asking. Would that have been the normal procedure, that it was looked at year on year instead of comparatively over from year to year? So you go back, if you're having an annual review, for example, do we go back and look at the review from last year and say, well, where were we last year? This is where you're at now. And I appreciate that probably a lot of the people around this table weren't there and are answering the question. But I do acknowledge that. But I suppose I'm just trying to get an understanding. Was that a failing in the governance then, that they didn't follow a proper procedure? Or was that they were following procedure but the procedure wasn't working, if that makes sense? Because I know certainly in the field that I worked in, you would have had a review or in terms of your work and where you're at and maybe where you need to go into other areas of learning to improve. And that would have been fairly standard. And you would look back and say how it was last year. So I'm just trying to get and maybe, Stephen, you haven't got the answer today, and I appreciate if you don't. But I just think at this critical time, we're 3-4 years on from when this was first flagged, and I'm still not clear as to whether that was just the procedure at the time or whether there was a failing of what the procedure should have been in terms of governance.
And you're quite right, it's hard to give a definitive answer because none of us here at the table were there at the time. However, the facts speak for what the facts say, and the facts are that, as you describe it, it appears that it was done in an individual year, because that's the only way you can really explain that this and didn't have the read-through in the following years. So, but again, it's hard to provide a definitive answer, exactly on that. But that is the obvious failing, the system failing in it to try and fix that. So,
yeah, and I suppose maybe then it's something we could. I'm not too sure who then would have the overall response, whether it's the department, Siobhan, or whether public health, because I know obviously you have an external role in and monitoring through public health agency. So, I mean, I would like to get that clarified to see at that time. I'm sure there's a policy document somewhere saying this is what should be happening, and I just haven't seen that yet. And I would really like to get that information if available.
So I maybe come in and Tracey can fill in the detail. But if you look, because I also have those questions. I think anyone looking at this, we've all looked at it and gone, how did that go on for so long? So if you look at what we've asked NHS England to do, it's more or less what you've said, Liz, to say, look, okay, what was the process that was supposed to have been followed during that time? Was it followed? So what were you supposed to do? This is from PHA point of view. Did you do what you said you were supposed to do? And was that the right thing to do? So in essence, that is what we've asked NHS England to do. So there would have been a series of data reviews and visits of the lab, which Tracey can detail a bit more. But obviously this went on for a long time. So that's essentially the question that we need to ask someone from outside to come and look objectively at this and say, right, show me what it was that was supposed to have been happening in the QA. I will check and assess. Can you provide me the evidence that you did, what you said you were going to do? And then I'll also give you comments on whether what you said you were going to do had any gaps. But in terms of the exact QA process at that time, I'll let Tracey fill you in with a bit more of the detail.
Yes, the Public Health Agency at that time, we did review and have meetings with every lab every year looking at their data, and that did include their individual screener activity and workload and performance data. And at those meetings, there would have been a full discussion, really, if anyone wasn't meeting the standard or there were concerns in terms of what the Trust was doing to address those, and to give us assurance that they were approaching that appropriately. As Stephen has said, I suppose in many ways the data that we get in the Public Health Agency is anonymised data, and we weren't looking at that on a long term for individual members of staff. Individual members of staff are responsibility of the Trust. So we were being told that things were being addressed, and we were satisfied with what we were given. But it is that long-term trends is the difficulty. Now that has changed. We now look at those trends and look at it over a period of years to make sure that is being mapped across.
Okay, but I think for me, I mean, when you look at the level of underperformance, I mean, some of these people were falling into the 50%, you know, maybe lower, that at that point it wasn't flagged that we have a serious issue here. And it did take for someone new to come in and say, we need to really look at this. And then, to discover that it goes as far back as 2008, that's only what we know about. Really, it's something I'm really struggling to get my head around. And I suppose, and we've seen the impact. And I do appreciate, and thankfully, I mean, the vast majority of women haven't had a negative outcome, but I think we cannot, and I'm not suggesting anyone has, but we cannot underestimate the impact on those women that haven't had the same outcome. And I suppose that just leads into my next question, just in relation to the 11 women, Stephen, you'd mentioned, who had the precancerous cells and then were required for further treatment. I think so you said some are still going on. Out of any of those women, did any of those go on to develop cancer, or was it diagnosed?
So of those women, there's 11. Some of them have had investigation, and then they've had various forms of treatment. Some are still in progress, because that's just the nature of this. It takes a little bit of time for various reasons. So, but there are no cervical cancers in that particular group. So it's I suppose that's just the facts are. But they did require some form of treatment and management to go forward. You know, whether it's colposcopy or whatever. Mm-hmm. But they are small numbers. You couldn't say, wouldn't like to say individually what people have.
Yes, no, absolutely. But I think I just wanted to be clear on that.
Either had it completed, their management, or they're in the process of getting that completed, and that still remains ongoing. And we obviously track that, you know, in the trust to make sure that continues on. And
I think it's important also to actually in terms of the treatment. I mean, we've heard, particularly in the last few days, just how intensive some of the treatments that are required for in treating cervical cancer. So I think that as well in itself is something very, very traumatic, that I think that had some of these been picked up sooner, many women maybe wouldn't have had to go through. And I think that's a really important point that we have to acknowledge as well.
Just for clarification, some of the women, the results were on recent smears that were undertaken, so it's not entirely clear whether they had changes that were in the past going forward. So some of them are their smears were on, they all had recent smears, and so there's always a bit of uncertainty exactly where that is. It's just the nature of the way the process was.
Particularly those women that maybe have had are under the SAI process, that maybe have whether it's evidence that they had misread smears and then have gone on to have been diagnosed, that the impact of that, the trauma of that, has been huge as well. So I'm led to believe that in terms of, I mean, like any health professional or any profession, there's the regulatory bodies. For those screeners, I'm not sure the name of the body that the governance body they would be reporting to. Were referrals made then by once this was identified, or what was the process then when things were raised? So
the HCPC, certainly we are in communication with the HCPC. It's a bit of a mouthful. They are obviously aware of this matter. They had some referrals from some members of the public, and we have been communicating with them and providing information to them in the usual manner with the details of the reports. We've provided those to them with all the various reports, the RC Path report and the more recent reports, and specific screener histories and data have all been provided to them in the usual way. So they are in the present considering that matter, and that's still ongoing deliberations.
So the members of the public referred to them. It wasn't done as part of this process, when it was first flagged.
So what we had undertaken is to undertake we had identified concerns. Then we had undertaken to do the review to find out was there a concern or not. So we've done the factual review. We're now actually in this stage now going to get the independent expert opinion to understand what it all means. So we've got the figures and the data, but we don't feel that we should make that decision. That's why we're asking the two external experts to look at the data to see what that means, and then of course we make appropriate decisions on that. It's complex, and as you already mentioned, it's not entirely clear cut because of the screeners. Some screeners, we expect some screeners not to always pick up everything, and there's a bit of a grey area in that, and therefore the review I think is be hopefully helpful and the external expert opinion will hopefully help us as well as part of that. But we're providing that information to the HCPC, and they're still in consideration of this matter themselves. So.
But, and I know it has been said in the presentations about, there is a kind of margin of error because of the nature of the screening, but I think the fact that there was such significant underperformance and that no one referred them to the body, I think what is concerning it, because I'm assuming then if members of the public made a referral and that has been acted upon by the HCPC, then obviously there was a case to be looked at. So I'm just trying to...
Well, I think my understanding is that they are there's various levels of thresholds, and it's always for them to decide, but they're in the midst of the early stages of their consideration of this matter. So, and we're just providing information to assist them in that, in their deliberations. So they haven't made any final decisions or anything of that nature, but they are working their way through that. And they appreciate it's complex and difficult area as well.
Chair, can I ask this a comment?
I was just going to finish and then we'll go on ahead very quickly. Then.
Let's just ask why, if it was another area of specialty that needed to be referred to a regulatory body, when does the trust do it versus members of the public?
Well, what you do is for any professional, you look at the issues, do a risk assessment to see what the issues are, and then sometimes you need to do more information or internal consideration of the trust to figure out is there an issue or not. So you don't, as soon as any concern is raised, you don't automatically refer somebody to the regulator. What you do is you do an internal process, and that's sort of standard practice. And most of the regulators actually they expect you to have done local processes within an organisation first, and part of that might be to do your own internal investigation or analysis to make this, because the trust has to undertake its own processes to see whether there's an issue that they need to deal with. So in this case, the screeners were removed from screening. So back in 2021, so there'd been action taken to remove them from screening at that stage, and then at that stage, so the safety was provided at that point. Then to figure out what does that mean. So they went down screening whenever the concerns were raised, and then the trust then had time to figure out what this all means, and then it led to the review and so forth that we have done.
Okay, thank you. I suppose just in conclusion, then there's 2 points. I suppose firstly, if ever there was a rationale or an example of why we need duty of candour, I think this is one of a key example, and we've had discussions at length at committee in relation to that and on the assembly floor, both in terms of governance but also in terms of responsibility of all staff to raise any concerns. I mean, if they felt that they were having issues, and I don't know the different circumstances that has led to this, but if there were issues impacting on them that was affecting their ability to perform to the standard that they should have been performing, that should have been flagged up, even as an individual. And secondly, for me, the key thing that we have to do here is to ensure that we are doing everything possible to restore confidence, because this is too critical. And I've said it at the start of the meeting, and I wanted just to finish on that point, because we probably need to do more, and that's why we want to scrutinise this as closely as possible, because it's far too important. And even at the end of Tracey's presentation, we have an opportunity to eliminate cervical cancer. We really do, and setbacks like this will only impact on that. So I just would implore everyone to put their shoulder to the wheel in that respect, because we cannot allow this to happen to any other woman again. So, Linda.
Thank you, Chair, and thank you to all of you for your. Some of the answers have probably raised more questions. Just in terms of what the Chair's literally just alluded to around the duty of candour and that responsibility, given that it was only been looked at from year to year, and I still don't really understand why nobody else was looking at that and saying, or why there wasn't some other policy. We've only got the terms of reference today, and unfortunately I was at the police board meeting all morning, so I haven't even got reading what the draft terms of reference are. But these are the kind of things I'd like to know if they're included, and if they're not, I think they should be. So were any of the screeners, because they knew I underperformed last year, I underperformed the year before, I've underperformed this year, but here's why I think I've underperformed. I'm not doing it intentionally, I'm not suggesting that for 1 minute, but here are the issues that I think I have. So is it that I'm overworked? Is it that I don't think I've had the right training? Did any of them raise those concerns? Were they raising those concerns with anybody? That's whether it's the Trust, PHA, RQA, anybody. Did they raise those concerns anywhere? And if they did, where did those concerns go? That needs to be part of this. It has to be. What they did or said or didn't do or said must be part of this, because if they didn't, I think that goes back to your point, the duty of candour. Why did they not? Were they afraid? Were they... I don't know. You know, it's just a question that I think absolutely needs to be asked and answered. And I don't expect you to answer it here today, because I understand that to try and answer that could prejudice other processes. But it needs to be in the terms of reference. Something about that needs to be in the terms of reference somewhere around this issue. I think that... Sorry. So just in terms of... I mean, the chair is focused on what has went wrong, and we might come back to you on those terms of reference again. I think that it's important that somebody somewhere has a conversation with somebody, whatever way it's done, with the people who are impacted around the terms of reference, and does it satisfy them? Because what's the point of doing another review or another oversight procedure if it's not going to meet the needs of the people impacted? Have a conversation with them. Because here's the thing, they might look at it and say that's not meeting my needs. But if there's a conversation, a two-way conversation as to why what is included, and why perhaps other things can't be included, then that allows the people impacted to understand why things may not be included. But if they just see terms of reference and have no understanding why things are or aren't included, it's not going to satisfy them. And if it doesn't satisfy them, truthfully, it won't satisfy all of the other women and the public out there. I think we just need to be honest about that. And like the chair, I do acknowledge that, and I'm delighted to see that there is an increase in the numbers of women going for smear. And I think probably, as much as people were concerned that some of this stuff might put women off going for their smears, it probably potentially highlighting it has had the opposite effect as well, where more women are actually more aware. And we know that whatever the percentages that aren't picked up, 100% of those that aren't tested won't be picked up. So I just think it's important to make that point again. I don't think we can make it enough. Going forward, so the HPV testing is actually what is now in place, and in the presentation you've said that is now under the Belfast Trust. Is all HPV testing for all of the North all being carried out in Belfast by the Belfast Trust?
Yes.
Okay. And are you confident that there is a good mechanism now in place for oversight of that testing? And I know it's an entirely different process to cytology. There's nothing similar. It's a test, but it's still a test. We still need to be confident that that test is right.
Yes, the Belfast Trust has a lot of experience in doing a wide range of different tests. So this has been added to their remit. So they have put in place all the staffing and are putting in place all the staffing and the structure that they need around that. They have UCAS, the external accreditation body, coming and overseeing that. They've shared a lot of the documentation with UCAS. They are coming to visit them next week, I think it is, to walk through all of that process, to see it in place and in operation. And then they'll feed back if there are any areas for further improvement with that. So they've been working very closely with UCAS through this process as the service has moved from elsewhere into Belfast.
Okay, so that's my first question. The time frame then between somebody now having their smear, the test being carried out, and then getting the results. So if you can give me the two time frames, so from your smear to your test, and then you get results. Do we know? It's probably similar. I mean, if you want to give me that in one, that's okay.
Okay.
Maybe that's confusing.
Well, at the moment, before the service moved into Belfast, we had to... The service that was being provided in the Western Trust and the Northern Trust stood down about 2 weeks before it moved into Belfast. So there was a bit of a backlog built up. Belfast has not quite got all the staff in place. They're still recruiting for some new posts. We had to work through through the transition as staff moved. Everybody was given the option to move to the new service in Belfast and had that choice if they wanted to do it or wanted to stay in their current trust and be redeployed to do other work. So there was very few staff decided to move, so there are some gaps in the staffing which are being addressed. So once they're up to full complement, the intention will be that those results get turned around, and especially HPV negative results should be out within 2 weeks. We know that's not happening at the moment because there's quite a manual process to authorise the results. So while they may be tested, they have to go in manually and authorise every single result. We are working on an IT development that should be in February, which will auto-authorise all the negative results. So as soon as it goes through the machine, it's a negative result is issued, that will be authorised and that result gets out to the GP. So it will speed up that process significantly.
What happens if it's a positive result?
If it's a positive result, then the sample is taken, a slide is made, and then that goes then through the process of cytology. So that will be primary screened, rapid reviewed, onwards to a consultant if needed. So that does take a bit longer to do. And at the moment, it's hard to know what that timescale will look like, but I would hope that all results would be out within 4 weeks of the sample being taken. But say there are still some staffing issues. The service is very new, and it's a big expansion on what was there. So they're working through those issues, but we are hoping that come now February we'll be able to clear a lot of those results that are still waiting because of this manual process that's currently in place.
Can we get an update, Chair, of what the time frame for the positive results is at an appropriate time? And you're not going to be able to give us that in a month, I get that, but for me that is a big concern because where it's positive. Then we talked earlier about the big difference between screening and symptomatic. So if somebody has a negative HPV test, but they go back to their GP because they are symptomatic, and they say, yes, I have recently, even within the last number of weeks, haven't had a negative HPV, is there an immediate pathway for them as being symptomatic, even though they've had a negative HPV?
Anyone going to their GP with symptoms, the GP will assess that person in terms of the significance of their symptoms, and if they felt that there was a need and clinical significance, they would be referring them into a gynae service. And that's the appropriate pathway for those ladies.
So can I get reassurance that GPs are being made fully aware that a negative HPV test should not be taken into account in that assessment?
Yeah, they have been repeatedly told over many years that negative cytology results, negative screening results, if someone presents with symptoms, you treat the symptoms and you assess the symptoms and you manage appropriately. It doesn't matter what your screening result was.
And the last point, Chair, on this new independent review, I think one of the terms of reference should be we need to find a way to include the women under the SIAs into the 17,500, into that overall review. There has to be a way of, because I understand why they're separated out, rightly so, in terms of how they are treated and how the level at which you'll have to investigate it. I understand that, but not including them skews the stats for me in terms of what went wrong over those years. And I think we have to find some way of including them. I don't know what that is, and I mean, you can come back to us on that. I'm not expecting you to answer that today, but I do think that there needs to be some way of us understanding the overall picture of what.
So I think that's why we've asked external people to look at this, because there are sort of statistical kind of problems with doing what sometimes seems straightforward. So that's why we've asked for that independent review, and they have both reports. They've got the CCR report and they've got the invasive cancer report, and they can also we can provide additional information for them if they want.
And maybe that is in the terms of reference. To be fair, as I say, we only got them today, so I don't know, but I just want to make sure that the things that we have in our...
From a statistical point of view, it wasn't as simple as just being able to add them in. So that's why, that's one of the things we've asked them to comment on, the significance of the cancers, but I don't think we can just necessarily add them in, 17,500.
No, and I'm not suggesting you add them in, but we have to find a way of including them. There has to be a way of
So they are looking at that as part of their work.
Yeah. Okay, thank you.
I'm conscious that other people...
And Diane?
Yes, thank you, Chair, and thank you for the presentation. I suppose at the outset of the presentation, and just to maybe reinforce and develop the last point that Linda was making, it seems to me today that we've been presented with a lot of statistics, we've been presented with a lot of process, and I fear that we're in danger of processing this out, but not actually listening to women. So I would like at some stage for the Trust and even the Minister and the Department to indicate to us how the voices of those 17,500 women are going to be heard in the process. Now, I know there have been meetings, and I know the Trust have held meetings, but there has been no formal mechanism, as far as I can see, for the voice of those women to be heard in the process. And I do attend, not frequently, the Ladies with Letters group, where I do listen to the stories of women who have been really terribly impacted by this whole debacle. And I do think that we need to find a process that allows those women. I would prefer if we had an inquiry into this, a statutory inquiry, where people were compelled to come and give evidence, and where it was all laid bare on the table. But we need to find a process that actually includes those women, a formal process. NHS England, Wales, Scotland, all fine, but the women that have been affected need to have their say. So that's sort of my starter for 10, really, on the whole issue. I, like the Chair, am completely taken aback by the fact that this went on for so long and just simply was not acknowledged, recognised, and nothing was done about it. I actually wrote to the Health Minister, the then Health Minister, in March, and asked, was the Southern Health where they've advised that no screeners had been preferred, the Trust had been advised that no screeners had been referred to the professional body. And the Minister wrote back to say that the review is ongoing. I accepted that at the time, and there is currently no evidence on which to base such a referral. Do you think that was the right decision then, and do you regret not referring them to the professional body now, given the evidence that we know?
So, I think, as I mentioned, there are, I suppose, two parts to the internal trust process. One is to think, are we able to maintain safety? So the screeners were not screening from around about October 2021. That's the first thing. The second thing then is to do due assessment of what the issues are. So the screeners weren't screening, so there was no further work that they were undertaking. On that stage, then, there was the external review by the RC Path, which provided information for us. There was an assessment of that done at that time, and that reported in 23. And then at that stage, then we undertook the review here, which provided much more detailed information on what the issues are. And now we're doing the external assessment, which Joanne has mentioned a little bit earlier, to provide some information on what it all means. It's still not entirely clear exactly what the review findings are, and that's why we're getting the external review. With hindsight, they might make a different decision. Would we have made a different decision? I suspect we still would have had to undertake our own internal processes, and that would have been to do the review. So the investigation we did effectively was to do this cervical cytology review and the RC Path review, and those provided information to us. They still provide sufficient clarity in that, and the screeners weren't screening, so they were, the public was protected because they had ceased screening. So there was no risk at that stage. What we were trying to understand is what the issue we were dealing with. So there's much more information available now. And hopefully we'll have more information in the next month to look at that in detail. But it still is a very, very complex area, as we've heard already. So,
I can't agree with that. I don't think it's that complex to know that people were not screening at the appropriate levels and were not doing it year on year on year. I don't think that's particularly complex. And I don't think that it's really appropriate to actually sort of say, I suppose a lot of this is a lot of ifs and buts and process that we've heard a lot about today. But I'll move on from that. But I do think that was a huge mistake. And I think that the fear among women who've been impacted is that ultimately no one will be accountable. Yeah. And I think that that is the exact fear from women that I've spoken to and spent time with. And I think that that's a fear. When you talk to the families of those women who have lost their lives, that's their fear as well. So, I'm sorry, but I just don't think that that's an appropriate answer. I suppose, like everybody here, I really want to see positive outcomes. I'm glad to hear that as many women are reporting for screening, if not more. I think that's a positive outcome, and I want there to be a positive outcome across Northern Ireland for this. I do desperately want that, and that's why I continue to ask questions on this issue. In December, I asked a question of the Health Minister in the Assembly relating to the Belfast Trust and the fact that the Belfast Trust had its accreditation withdrawn in 23 and 24 from 31st of October 23 to the 7th of June 2024. I asked for the reason why the Belfast Trust had its accreditation withdrawn, and I'm going to read out onto the record of the committee the actual sentence from the letter that the Minister sent me. So the UCAS decision to temporarily suspend Belfast Health and Social Care Trust was based on, in part, issues such as documents not in place to manage underperformance. Belfast Trust had achieved the target of 95% in high-grade lesions, but did not meet the target of 90% in all abnormalities. Now, it doesn't say what target it did reach. So I suppose my question today to Joanne and Tracey, I suppose, really, and to Siobhan, is do you have performance data for all of the trusts between that period, say 2013 to 2023, and will you share that performance data with the committee so that we can be assured that across all trusts in Northern Ireland that screening programme as a whole was achieving what it should have done?
We do have performance data. The standards that we use for monitoring performance have changed nationally in that time period. So the data that we use now is different to the data that was done at that time. But we do have that data for every trust over those years, and I'm sure we're happy to share that. Okay, and you can, of course, give a rationale and explanation around the changes in how the data is treated. I think that's quite important for transparency's sake in relation to this particular issue. I suppose then that leads me on to another question which I've actually asked the Minister again in another letter. Sorry to the Minister for so many letters. Which was why, given that the Belfast Trust had lost its accreditation for documents not in place to manage underperformance and not meeting the target of 90% in all abnormalities, was the Belfast Trust awarded the contract for HPV testing? So given the fact that the Trust had lost its accreditation and was not accredited during the period of the commissioning of the service, why did the Belfast Trust be awarded the service? Belfast had their accreditation reinstated at the time we were commissioning the service, and the panel met to review those submissions from all trusts. So the accreditation had been reinstated. I can't obviously speak for the Belfast Trust, but my understanding in terms of the documentation was that the documentation was not there and available to the assessors from UCAS who attended on the day. And some of that was because the Trust couldn't put their hand on it. But that documentation was later found within the Trust. There was staff had moved on. The service had actually moved from the City Hospital a number of years ago down to the Royal site. And when the managers were back in place and had come back, they weren't there on the day of the assessment. that the documentation was found and was then subsequently shared with UCAS. And UCAS subsequently assessed all of that and cleared them that they were satisfied that appropriate action had been taken at the time.
My understanding is at the time of that the service was commissioned, that the Belfast Trust were not accredited and only received their accreditation back again a short time after the service was commissioned. But I would love you to write to me formally on that. I think that would be very, very useful. Sorry I lost the papers is a poor excuse when we're dealing with something as important as women's cervical smear records and the management of the laboratory that's doing it. I'm at a loss on this one. Can I also ask, did the Belfast Trust carry out cytology examinations during the period when it was suspended and had its accreditation withdrawn?
It did. There was a risk assessment. First of all, accreditation by UCAS is not a regulatory body. We did a risk assessment of all the performance of the Belfast Trust. That was shared with the SPPG and with the department, and there was agreement that they could continue to do their own work during that time while they were working to reinstate their accreditation. So the accreditation was around documentation, but it wasn't felt that it was a key quality in terms of the delivery of the service.
So you're saying that the Trust, the PHA and the department gave the go-ahead for the Trust, even though it wasn't accredited by a professional assurance body, to continue to do the cytology test at that time?
At that time, the decision was taken that the risk assessment gives sufficient assurance that the Trust was safe to continue to operate and provide cytology.
Okay. In terms of where we are now, again, another correspondence from the Minister actually confirms that the Belfast Trust has not... Sorry, just before we move on from that, the Belfast Trust was not accredited, and in fact it had lost its professional accreditation during the time of the commissioning process. But the Northern and Western Trusts were accredited for HPV testing. Why? I mean, I struggle to understand why we would award to a body that wasn't accredited when we had two trusts that were accredited. Is there a rational explanation for that?
So there was an expression of interest process that happened, and whatever trust wanted to put themselves forward to deliver the new single service were invited to fill in an expression of interest. 3 trusts did that. The expressions of interest were scored on a very wide range of criteria, and they include UCAS accreditation was one of the criteria, but there are a lot of other criteria, including deliverability, the engagement and involvement of virology services, the ability to provide enough staff, the ability to have a very resilient service and be able to cope should something happen, like the laboratories flood and things like that. Belfast Trust are a regional provider, and they score well and things like that because they're used to delivering services like that. So UCAS accreditation for cytology had been restored by the time the bids were assessed. UCAS accreditation for HPV testing specifically can only actually be gained once the service is in place. So the Belfast Trust are going through that process at the minute, and I think, Tracey, you said they're coming next week. Yes, and one of the challenges in this is UCAS as a body there's like a waiting time before they can give you an appointment to come and do your assessment. So that's one of the reasons why there's a delay as well. But there are a range of things that were looked at when we're making the decision on the scoring. And the scoring involved people from PHA, the SPPG, the Northern Ireland Pathology Network, and an external expert as well.
Okay. Is that you, Diana?
So, no, I've just a couple more questions.
Okay,
It's
we've quite a number of people still waiting.
The HPV, so sorry, in terms of the scoring, I'm presuming that, and I don't know the scoring, so trusts that were already accredited were scored the same, or as a trust that wasn't accredited, is that right?
Not for that particular field. So it's a bit like, if you're assessing anything and there are multiple criteria, they wouldn't have scored as highly for having HPV accreditation in place because they didn't have it. So they didn't, but they scored more highly in some of the other fields, like workforce, the ability to provide a regional service.
Just very, very quickly, because I've had more than my fair share. You said that you wanted a resilient service. Are you satisfied that we have a resilient service, given that 5,000 samples were sent to Gateshead for testing because of the backlog? You've talked about staffing issues. You've talked about IT issues. I've talked to GPs who said it's impossible, the wait time now to get results back from HPV testing. Are you satisfied that we now have a resilient service?
Yeah, we think we have a resilient service going forward. It is a new service that we are still waiting. As I say, there's been some recruitment issues because staff from other trusts didn't move into Belfast, so they've had to start and recruit some of those vacant posts, and some of these were new posts for the new service. So that process does take time to work through. It's only been operational since the 1st of November. And as I said, the other two trusts that were still providing the service actually stood down their service 2 weeks in advance of that for different reasons. So there was a backlog of 2 weeks of work which had built up that they were starting with. And that's why 5,000 samples were sent to Gateshead to try and to clear that backlog. So they weren't starting with that to begin with. Going forward, as they were working through to make continuous improvements when they have all staff in post, and as I say, the IT development, it's not an IT issue, it's an IT development in terms of auto authorisation of those negative results, which will speed up the process. That's in place in other places, in other labs across England, so we want to put that in place here as well, and that will speed up that turnaround of results, and I think within the next month or two we'll start to see real improvement in that. So yes, it's an early new service, and we need to give them a little bit of space just to get up to speed and to get everything in place that they need.
Okay. Alan Chambers.
Thanks very much. When we had the slides, or the presentation slides, one of the slides said screening saves lives, and absolutely we all agree with that. But to inspire confidence and to give that statement credibility, the system has to work, and in this case it failed abysmally. And the job of the screeners, it's not just routine work, it's life and death work that they're carrying out. And as others have said, that this went on for a long time, and the buck stops with someone, and in this case the buck seems to have stopped with the screeners. We haven't heard of any disciplinary action been taken against senior management, but there's got to have been senior management who had the responsibility to review these performances and do something about it. So somebody didn't do their job, and they're maybe still in their job, I don't know, but there's certainly no evidence that any disciplinary action was taken against senior management. Now, we were given the slides also give us a lot of figures comparing the performance of the Southeastern Trust, the Southern Health Trust with other trusts across Northern Ireland and indeed in the United Kingdom. And if you were an outsider looking in and you didn't know about the particular circumstances of this particular situation, you'd say, well, not much to see there. The Southern Health Trust doesn't seem to be out of kilter too much with other figures across the rest of Northern Ireland and the United Kingdom. But there's a big difference. And the big difference is, Tracey, as you said, behind every stat, there's a person, there's a family. And the difference between the slides that we've seen and the performances across Northern Ireland compared with the Southern Health, the big difference is that over 17,000 women received a very, very concerning and worrying communication that must have caused a lot of concern, not only to them, but to their families. And I'm sure there was a lot of sleepless nights that were caused by that. So I don't think it's really reassuring to compare the figures and say, yeah, they weren't that much out of kilter. They were out of kilter, without a doubt. And one of the things, we had a briefing from the lady with letters earlier in the week, and I asked them about, what message would they give, despite their experiences, what message would they give to other women? And they were totally passionate in the message that every woman should take up the smear test as and when it comes the time to take it. And I think that's the message that this committee sent out today. Do not put off taking a smear test just because of this particular situation. And the figures do show that maybe it hasn't had that big of an impact, but even if one person puts off going for that smear test because of what's happened here, that would be terrible. Thank you.
Thank you, Alan. So no questions, I think, Alan, there from that, is there? But
well, I'm just wondering, was any senior management held accountable? Was there any disciplinary action taken at a level above the screeners? Because, as I say, the buck does seem to have stopped at the screeners.
I think that is the issue, that I don't think that has happened to date, and that's the point I was also making in relation to even all of the reports we have seen. None of that has been addressed. So hopefully that's something will come out of the independent review, but that remains to be seen. So, Colm?
Yeah, maybe just building a little bit on what Alan has said. I think probably one of the most galling things is that whilst this is absolutely a significant health issue which has impacted people right up to and including death, it appears that it's because of a HR issue. It's because somebody didn't do their annual appraisals correctly. Because if somebody was year on year on year on year not performing, and a service was year on year on year not performing, that is a HR issue. And that has resulted in people potentially being missed, and potentially the result of that missing information has resulted in death. And we will never know whether that was the case or not. I don't think no matter how much we look back, will we ever find out whether that was the case or not. And I suppose, Colm, this question is for yourself, and you're kind of landed on it. You're new to the job, you're in an acting role, but was this the practice for HR appraisals within the Southern Trust not to be cross-referenced year on year, or was this an isolated issue within this specific role? And does the Trust know that for fact?
I suppose it would be impossible for me to give the committee a definitive answer to that question, Colin. I think Dr. Austin tried to outline what clearly had been identified, and I think there's no question that those episodes were looked at in isolation, but it would be impossible for me to give a definitive answer with regards to practices in those days, other than to say, I think it's fair to say even before this, there's an infinitely more stringent attention afforded to staff appraisal, and that is something within the Southern Trust across all disciplines that we have significantly promoted, and I think over the last number of years our compliance has significantly increased across all disciplines, and particularly down the professional lines it is of the utmost importance to us now.
Well, I'm glad to hear that. I hope that you take that message from the committee and go back to your senior management team and say, can we make sure that anybody that does year on year appraisals, that there's a reference to the year before to ensure that somebody has either improved or reduced in their quality of provision? Because a little bit like the chair, I was also in a career before I went in to the Assembly, and I was subject to year on year appraisals, and you had to set targets from one year to the next year for what you wanted to improve, and you wanted to put in your training plan as to what you wanted to do. And actually in a lot of places I did that with volunteers in the organisation that I worked in, and to think that people that were doing something as serious as screening the potential for somebody to have cancer or not wasn't doing that is really, really frightening, and will be of no comfort to any of the families. And the presentation that we received, and again following on from what Alan said, I'm going to hope it wasn't the intention, but it really came across quite blasé. It was like, look, there's absolutely nothing to see here. Everything that happened in the Southern Trust is perfectly normal. Don't worry about a thing. Look at these statistics. They're equal the whole way across. And for the families and for the ladies that are here present that have all been impacted by that, that is no comfort. And I hope, as I say, I have faith that it wasn't. But if we're doing the presentation again in any other places, it comes across almost as defensive, as in, look, we've done what we've done here, and there's everything's normal. So we're here because we know things weren't normal. So therefore, to get told that it is a bit worrying. And one of the things, it's maybe very specific, and I could be wrong in it, but we referenced that there were 207 cases in the Southern Trust over a 10-year period, and that 14 was the UK average. If we had 207 over 10 years, that's 20 per year, which means that we're about 7 above the 14, which is a 50% higher incidence. Would that not have spiked some sort of an analysis, assessment, input, concern, worry? Or am I reading that figure wrong? Because I think it was 207 over 10 years.
There was 207 diagnosed in the Southern Trust between 2009 and 2023. Okay. So it's 14 years.
14 years, okay.
The data from the Trust through the audit, that 207 figures is people who are diagnosed in the Trust. The data that comes from the Cancer Registry is people who live in the Trust area. So there can always be a bit of difference, because you may live in one area but be diagnosed somewhere else. So they're never going to completely tally. So they're coming from two different sources, so you can't necessarily completely.
So it's not something that can be directly. Just in terms then, finally, in terms of the peer review, there's just something inside my head that has a wee alarm bell whenever that goes on. I think to another significant review that has been undertaken at the minute, that the peer reviews are often undertaken by people that know each other and that maybe trained together, or people that maybe work together at some stage. Has an assessment been consciously undertaken to make sure that the independent review is being carried out by people who have no knowledge of people working in the sector here, either directly or indirectly? Because sometimes the medical fraternity is quite small, and those that are actually carrying out the review were bodies of those that are being reviewed, maybe just to ensure that transparency. But can I ask, has that specific question been asked of those that will undertake the review?
So I maybe answer this. The reason that NHS England are being asked to do the review, quality assurance of cervical screening programmes is a very specialist and not an area that an awful lot of people across the UK are involved in. So there's an inevitability here that people who are involved in our programme will have come across some of the experts in England, Scotland and Wales at different meetings. That's inevitable. We can't do away with that. The reason that we asked NHS England to do it rather than ask a couple of people, so we could have gone and approached people, that we want to get it done by NHS England, is they have a peer review process where they will look at their own services as well. So NHS England, I think, for example, there are 8 kind of screening labs at the minute, and they have a peer review kind of process. It's a very formal process. They'll be able to measure things. So do the people involved in our screening programme, have they met some of the people who will be involved in doing the review at meetings and things? Yes. Have they had close relationships, trained with them, anything like that? No, to the best of my knowledge. But the reason we want the organisation rather than individuals to do is to try to give it as much robustness and independence as we can.
there's not a lot we could do about that. I don't have a lot of faith in an independent review if the people know each other, because whilst it might be inevitable, I don't think it's independent. If I was to review a party colleague, I'm going to have a certain amount of bias that's going to be carried across there. So it's just...
So I suppose a couple of things. The first thing is, I have absolutely nothing to gain in getting someone to just give me a fairy story or give me something that isn't true. I want to know what happened here. I want to make sure that, whatever we do in quality assurance is the right thing to do going forward. So I have no interest in getting something that kind of says, oh, it was all fine. I would want them to identify where there are gaps. The second thing is, this is not about individuals and personality and opinion. This is about applying standards, measurements, objective things, rather than just, well, actually, I feel whatever. So I would give you those two reassurances. I really couldn't be bothered I just don't want to have a review that is a nothing review. I want something that is honest and explores the facts and gets to the bottom. I mean, that is what we need to do. And the second thing is an objective process rather than a very sort of woolly kind of thing. That's what we want.
I don't doubt your motivation, and I said that at the start. I'm just still going on the record as saying I don't believe that an independent review that is carried out by people that may know each other is independent, because by its very nature it's not. Now, maybe there's not enough people to be able to carry out a review that's independent. That's a different point. But an independent review, and we have had it in other spheres, in other reviews that are carried out, I'm sorry, they're not independent. It's impossible to be independent if you know the person.
I take your point, but it's independent of the organisation. It's independent of the health and social care system in Northern Ireland. We made very sure that we didn't include people from Northern Ireland in any of this because it is a small place. We have done our best to get as much independence as we have, but there's a balance between getting independence and getting people with the right skills and experience and capability to do the review. And while they may know people, they don't know them personally. It would be a professional, perhaps as a training thing or something like that, but not a deep and personal.
And is that something that could be checked? Because that's quite simple. If somebody's carrying out the review, to just simply say, do you know people that operate within that sector?
So as part of any process like that, we would ask about conflict of interest.
Sure.
So I'm sure whenever you fill out various conflict of interest things, you sort of say personal friend, financial. So those sort of checks would be there. But if I can assure people of something, is that we want to get to the bottom of what happened. As has been alluded before, this happened a while ago, before we were in post. We want to make sure this doesn't happen again, so that there's nothing. I want this to be the right thing. Tracey wants this to be the right thing. Everyone wants this to be the right thing and get to the bottom of it. And genuinely, that is what we're trying to do. And I think throughout the process, with all the different things that we have done, we have really tried to get to the bottom of it. And you mentioned the 17,500 women. That is something that is very real to us. I think the presentation is factual because it is given numbers and facts, and it's hard, to strike a balance. But those 17,500 women are very real. We're very conscious of it. And in fact, we really agonised over the decisions about sending out the letters because we knew because a lot of people upset, the vast majority of whom the Royal College of Pathologists report said they will have had the right result. So we didn't want to be going upsetting a lot of people, worrying a lot of people who probably had the right result. But we wanted to get to the bottom of it, and we wanted to make sure that we had found any abnormalities that would be missed. So we're very conscious of the annoyance that would cause to those women. I'm very glad we've got to the end of the process and the vast majority have been reassured. But I'm very sorry that some people have needed treatment. I'm very sorry that people have cancer, and you've mentioned how awful that is for them and their families. So it's not true that we just look at the numbers. We're very conscious of every single woman who got a letter.
Thank you. Danny?
Thank you, Chair. A lot of the questions that I was going to ask have come up already. I do want to reiterate I share the Chair's opinion that I don't understand why the Trust didn't refer these people to their professional body when they were quite willing to suspend them. They knew there was a problem. Restrictions were put on practice and such. I find that very confusing. But I wanted to get into something you mentioned just about staff moving to Belfast, and one of the criteria you mentioned on Diane's question was that Belfast could provide a staff cohort, and that was one of the criteria that obviously resulted in them winning the contract. They haven't got that at the minute, is that correct?
So all of the laboratories would have needed to recruit additional staff in, but Belfast had the biggest staff going forward. And Tracey can maybe talk a bit more about the details. She's been heavily involved in the implementation.
Yes, I mean, no laboratory in Northern Ireland, as it stood, could have delivered this on its own. It did need an expansion in staff. Some of the laboratories we had were surviving with locum screeners, so they had very few permanent staff still in place. So Belfast, certainly in the bid that we got from Belfast, they had a clear plan in terms of how they would expand the service, the scale of that expansion. There was, as I say, a people work stream, so everybody who was working in this area elsewhere had the option that they could move to Belfast. And that would have immediately, if they had done that, would have immediately filled any vacancies that were there. But that didn't happen. Staff chose to stay where they were and get redeployed into other areas of their own local labs to address other pressures within services. So it meant that Belfast then was left with the gaps because they weren't filled by staff coming in. So that does take time to work through that recruitment process.
So Belfast had a plan, so they got a tick, they got the contract. They had the plan then didn't work. Is that fair to say?
Well, everybody had a plan, and those plans, as Joanne has said, the process that we went through and the panel went through, I think there was 13 criteria. They were scored. Everybody was scored against in terms of their submission. So having a plan in terms of resilient staffing was one of them, but there was lots of other aspects to that, and they were all scored across those. So, as I say, that's the process and very open and transparent and fair process that we went through.
Is it fair to say that plan didn't work?
I don't think it's fair to say that. I think their plan was what staffing they needed. And as I said, no trust was going to be able to deliver this with their, at that point in time, in terms of the staffing that they had. They were all going to have to recruit staff in to do that. So Belfast is in no different position than any other trust would have been if they had been awarded the contract.
And what's the staffing like at the minute? Out of 100% fully staffed, what is the...
Well, I can't say fully. I can't say in terms of percentage. There was a couple of new posts created in the service to. As part of that, there's been a bit of movement in staff in terms of there's been a few more senior posts created. So more junior staff have applied for those posts and then moved up and left a gap underneath them. So it's still quite a fluid picture as they settle down and work through that.
Is there a reluctance to go and work in this area?
Is there what, sorry?
A reluctance to go and work in this area?
Well, I think you can probably imagine in terms of the amount of sort of issues that have been raised, how public this has been over the last 2 years. When you have staff who are working at very low grade in some of these laboratories, when they are constantly, listening to the news, the media, social media, issues being raised about the...
It's the emergency weather.
That's the weather warning. It's our emergency phones are all going off.
It's my new way of telling everybody take the time to sit back. So that's just, I suppose, a reminder that there's a red warning.
Yeah.
Coming.
Nobody cares about you.
They're probably coming in phases. It'll might go on for a while. Yeah. I suppose staff. If you're sitting in a lab doing this type of work and you're getting a huge amount of pressure, you're looking around at what's happened in other labs. You're looking around at staff being referred to the professional body, and I imagine it's extremely difficult for those individuals who are still there. When you talk to the staff who work in the labs, these are extremely, they're not highly paid staff, but they're extremely proud of the work that they do. They're extremely committed to the work that they do. And the labs that didn't get the contract for the new service, there's a lot of disappointment among the staff that were in those labs. They are extremely proud of what they have done for the women of Northern Ireland over these years, and it's difficult for them to see what has been happening. But also, they're looking at their colleagues and saying what has happened to people being referred to the professional body. A lot of focus on screener performance, and there must be the fear there that if I miss something, everybody will miss something at some point. But if I miss something, the pressure that is putting those staff under is extremely difficult. And trusts have had to do a lot of work with occupational health and everybody in supporting those staff during this, because they've been under extreme stress and difficulties, because they're doing such a very intense job, a very critical job. You don't want those staff to be under stress, because if people are under stress, that's when they can start making mistakes. So there's been a huge amount of work put in to support those staff around that.
I appreciate that, and as Alan pointed out, it is a life or death job that they're doing. Yeah. It is incredibly important and clearly has huge ramifications for the people who it involves. I do want to ask just one more thing. This was ongoing for 13 years. Do we know if people who were working for... It's me, isn't it?
It must go so phased.
Sorry, Danny, go on ahead.
No, you're grand. I would imagine that people move between trusts when they're doing jobs within health trusts. During that 13-year period, were there people who had been involved in the scanning process in the Southern Trust that had moved to other trust areas? Belfast Trust, for example. Is there a follow-up there?
There's very little movement of staff around those laboratories.
Right.
Occasionally you do, but there doesn't seem to be a huge amount of movement of staff. But certainly anyone in the Southern Trust that had moved, that there were concerns about, that had moved elsewhere, their performance after they moved was reviewed as well. So the whole picture is looked at.
So if somebody moved to another trust, their performance at the Southern Trust had been reviewed and it was picked up in the new trust? Is that the case?
So that their performance when they moved to their new trust, I suppose just to give you some assurance, when anybody does move, or if they employ a locum to do this type of work, they do have to come and provide their all their performance data and things from the past as well. So
over multiple years.
I can't answer that, because that would have to be a laboratory person would have to answer that. But I know that they do ask for them to perform and provide their performance data before they will allow them to start screening in their lab. And they would often do a period of settling in as part of their induction. So things would be double screened initially, just to give assurance that they're happy with their work before they let them off on their own to do it. So they do have systems in place for new staff.
Do you know if anybody who was underperforming at the time and was known to have been underperforming moved to another trust?
Well, I think that's recognised in the RC Path report, that there was one screener in the Southern Trust during this period had moved to another trust during that period.
Okay. And do you know that their underperformance was picked up in their new trust?
Their performance after they moved to their new trust was reviewed and was fine.
But their previous underperformance?
Well, no, I don't think they don't go back. They didn't review, 5 years ago what they were doing somewhere else. That wasn't done, and that wouldn't be normal practice at that time. Certainly, it wouldn't have been normal practice.
Okay. No problem.
Okay. Thank you, Danny. Nuala?
Thank you. And I know it's been very long, so I'll ask my questions really quickly, but do appreciate that it's a very important issue to scrutinise. And one of the issues that's been mentioned by a lot of people is that you weren't in post at the time, and appreciate that you don't have all the answers as to what happened then. I think that speaks volumes as to why we need public inquiry, so that people who do know those answers and knew what went on at the time are able to actually answer and be questioned. I want to go back to the beginning with regards to the screeners. Why were they underperforming? I'm sure that people have been spoken to and that there have been interviews and discussions. So why were they underperforming?
Do you mean the reasons why people might underperform? What sort of things?
Why were these screeners in particular underperforming?
So I suppose we'll never quite know that. Going back there to ask people retrospectively 10, 15 years back would be challenging. Like my understanding of why people underperform, you mentioned about they're under stress for particular reasons, you get distracted, it's a challenging job to do, they have to look at various particular things, requires attention span to look at it. Some of the cells are that they're looking for are different characters, and there's a whole grading process for that that college members speak about. So some changes are easier to spot than others, and some types of things are more clear cut. Other ones are really quite subtle changes. When you look at the slide, I'm not a pathologist, but you have to look at the slide and they have to focus in and out in different layers of the slide, so that the cells it's not just like a picture book. It's actually quite complex work to do. So there's lots of factors in it that require them to do that. Then they've got a time period to do it within, and so they have to scan in a methodical way, and there's different ways of doing that. So you might never actually know particularly why, because again, even in the
year, has the trust asked them? Right. Not even going back 10 years, but most recent years.
I don't think we've asked them particularly about that. No.
Why? Why don't we ask why they were underperforming? I mean, if you're not meeting your targets in your job, and you have one-on-ones, you need to ask why and what can we do to fix that.
Well,
so will that take place?
I suppose the difficulty is, the staff may not actually know why they're underperforming. That's one of the reasons. If they knew why they're underperforming, they would be able to adjust things. That's why you do the performance monitoring, to look for things, and then you put in place the recognised training for that. So you don't necessarily rely on staff. That's why you have that sort of.
And but the training didn't change anything whenever the PHA picked up, or whenever the isolated incident picked up. Sorry, not PHA. In 2013. Was there training initiated then?
Well, the staff would have gone through whatever the recognised review screening was. They would have had double screening, or they would have had gone to course. They go down an annual course to try and to make sure that they're up to scale, up to spec in their screening. So they do all that sort of work. That's what the process would have been at that time.
But it didn't help.
But it obviously didn't help. Clearly the data tells us that.
And I think that's really important as to why we need. Why exactly did they underperform, and who else knew about it? We all know about the neurology inquiry and the colleagues that knew about Dr. Watt at the time. Everyone apparently knew about him. Everyone had concerns about him. Nothing was done about it. And it's never just the people sitting beside you that know about it. Never. It's always much wider than that. And that brings me to the timeline question. The report that was published in December, it said in October 2021, senior staff within the laboratory identified a concern in relation to screener performance. It was escalated. A review from 2008 was undertaken. Escalated to who? What does that mean? The issue was escalated and a detailed review. So escalated to who?
So the staff realised there was an issue, they'd stopped the screening, then they gathered information to understand what they were doing, and then they provided a report, and then that went to in due course up to the senior management team of the trust.
But who was the issue initially escalated, and who made the decision to take the detailed review from 2008? Was that the senior management team?
Sorry, say that again.
So the timeline is October 21, a senior staff in the laboratory identified issues in screener performance. The issue was escalated. This is in the report. The issue was escalated, and a detailed review of all screener performance from 2008 was undertaken. And then a comprehensive report was collated, and then that was presented in July 2022 to the Southern Trust senior management team. So who was it escalated to in October 2021?
So the lab staff who realised the issue, they did the analysis of the screener performance that you mentioned. Then they compiled a comprehensive report on that. That was done by the management team of the lab service. Okay. And then that was then escalated up to the senior management team of the trust.
Did the senior management team know before July 2022 that this was happening?
The review. So I think there'd been some previous discussion about the ins and outs of that in a few months prior to that, while the paper has been prepared, as I understand it. So, yeah.
And did the PHA aware that this was taking place from October 21 to July 22?
I will check with Tracey about the timeline, but I think, Tracey, we were first informed in
July 22, I think, when after went to the senior management team.
Okay. And then it says after that, a risk assessment, a decision was taken in July 2022 that a risk assessment would be required. Why was that why was that decision only taken in July 2022 instead of October 2021, whenever senior staff member noticed something that was so concerning?
So the difference was that at the time the staff members were looking to find out what the issue was. They were sort of considering, is there something here or not, and they were looking at that. When it came to the senior management team of the trust, they were thinking, well, is there a need to look back at patients? So, and therefore what they did is they looked at the departmental look-back review guidance, and then it asked for specific risk assessment. Part one of it is to do a risk assessment, and there's a formal process for doing that. So at the time, the senior management team of the trust said, there's a possibility this. They recognise there might be a need for considering whether or not you need to do a look-back or not, and therefore they followed the guidance. You do a risk assessment. That's the first thing you're mandated to do by the departmental guidance.
But that wasn't until July 2022, though, that you did the risk assessment. Yet they found out in October 2021, and the reasons why this is important is because the regulatory body, I think in November the hearings took place. They deemed it sufficient for suspension and action. They also outlined that the people weren't protected enough. There wasn't enough sufficient protections put in place, and there's a gap. I mean, notwithstanding the 13-14 year gap, but there was a gap between October and July, whenever decisions and action could have been and should have been taken. And the reason why I highlight this is because historically, within trusts, and to be fair, not just the Southern trusts, there is a real reluctance for transparency, especially when it comes to any serious adverse incident or any other incident that takes place. And it almost seems like it's I'm not saying it took place in this instant, but a covering tracks rather than full transparency from the outset. And I just don't understand why a risk assessment was not carried out for some months following the first person, supposedly the first person, to notice that there was a concern. And during that intervening period, whilst the report was being confined, was there no one within the senior management team or anyone who undertook to actually speak and assess what was going on, and if this was much wider and bigger picture, as well as the individuals within the laboratory management, given the fact that that was a significant issue?
And just to think a bit further about that, so the staff who realised the issues, they were reviewing the stuff. They did their own sort of individual professional risk management, such, but they didn't do the formal risk assessment, which was the external risk assessment done by the Royal College of Pathologists, who were the external party were asked to do the formal look-back guidance. So they would have done their own assessment, because they obviously had to do a risk assessment to say, well, we need to escalate this. So then they did that. So they would have done something, but it wouldn't have been the formal. I'm not sure that helps or not, but there would have been various stages to that.
I think this actually gives a lot of food for thought in terms of how we change things moving forward, with managing and assessing risk and preventing from day one. And I recognise it's not just the Southern Trust, there are other trusts as well concerned. I do want to ask as well, and I'll come back to the department on their look-back review guidance. I think that's not on you, that's the department to answer those. But I did have another example or another question in terms of the actual quality assurance for the PHA. And I understand it is every 3 years, did you say, or every annually from the PHA, just to keep me correct, for quality assurance?
We look at annual data, so it's once off on an annual basis.
And during the 13-14 years, did you ask about those underperformance, or did anyone in the PHA ask why, or try to find out why they were underperforming? And is there going to be paper trail anywhere that highlights steps were taken and why it was signed off each stage?
We don't sign off.
I know you don't sign off. I'm using that as a loose term.
If we identify in those annual meetings with the trusts and with the labs that there is a performance issue, we do ask questions in terms of what the trust has done, how they have managed that, Have they got a protocol in place for managing underperformance?
Did
have
that
they
happen
followed
at the time?
it? So that would have happened at the time.
So the Trust would have been aware at the time that the screeners were underperforming significantly, were underperforming?
If that was the data that was shown to us at that time, and that's what we looked at, that discussion would have taken place. Yeah.
So then it goes back to the Trust again that there was people outside of this senior staff who knew. And I think it's very important, and I recognise that you can't answer, but it's very important. And it's not to, be able to, like, publicly shame any individual, because that's not what it's about. It's about a collective responsibility within, the trust management, within each trust, that what happened. And there should have been a paper trail that highlighted significant underperformance over those years and what was done. I don't think we'll get those answers today. I do think that it will be in an inquiry going forward. But I think it's one thing we will take on then is the department's look-back review guidance that you won't be able to answer, and we can get to the department on that.
Can I just ask, did that conversation happen multiple times each year?
Well, any lab that is visited where there are issues raised, that conversation would happen looking at that specific data. I think to understand that performance of an individual screener is much more than just one statistic, and that is looked at. Those staff also undergo external quality proficiency testing, so they do test slides twice a year that they report on, which happens across the whole of the UK, and they're scored, and it's like a test they have to score a certain level at. So there are different levels of how their performance is managed and assessed. So any bit of data that's reviewed is reviewed in that wider context. What's happening in the lab, what's their score of their other performance data, are there any particular issues with that person, have they been off on extended leave, on sick leave, that may be an issue. So those sorts of discussions do happen. Yeah.
Okay. And last but not least, Orlia.
Yes, thank you so much for the time that you spent with the committee today. And all questions so far, and I'll just finish off with two short questions. I do want to say I think it is important from the outset, Stephen, that you obviously have gave the recognition that there was systemic failure that has obviously led to the situation that we're in, and of course the apology that you said at the outset as well. So my first question is just to follow up on some of the issues that Danny had raised around the staff and the management that were there at the time throughout those years of 2009 and 2023. And you have mentioned, Stephen, that a lot of those staff and management are no longer there. And my question just was around how has that impacted on your own internal investigations, reviews? Has that had an impact, if any, in terms of people who have moved on, who aren't there? And then my final question was around the SAIs. So there's three currently underway, three SAI reviews underway that would be including then people who have been impacted within those years of 2009 and 2023. And it was just a broader question around, would it be normal for SAIs to be sort of flagged up or taken forward in terms of laboratory and screening processes? Is that a normal part of the process that every now and again an SAI review would come up? Thank you.
So just to take the last bit first, the SAIs, there's a number of SAIs that we're looking at, so they're being reviewed to try and get those are women who've had cancer, so that they're part of that. The reason they get SAIs is whenever they do the audit of invasive cancer, the slides are reviewed as part of the audit, and if they categorise the slides as sort of there's no abnormality found, the second category is that there's something there, but it's quite challenging to find, and you wouldn't expect people to find it because it's very, very subtle. The third one is something that's a bit more obvious, and you would have expected people to get it. So that's like Category 3, and all Category 3s under the guidance that was published in 2019, I think it was in 2019. They're categorised then to produce an SAI. So any cases like that then go forward to SAI investigation, and that's to try and gather any learning. And they will look at the broader picture of that lady to make sure that there's learning for the system comes out. So, and those are ongoing. So any woman who has cervical cancer goes through the audit. If there's an abnormality in the Category 3, they get an SAI as part of that, and the women are invited to take part in that. So some of those are going on, and they're done. All the trusts do those across the UK if such things happen. So it's just a standard process for doing that. So. And the reason for that question, I suppose, was just if we're thinking, if we're going back earlier to, pre-2009, if when we're talking about a systemic failure, how long was this systemic failure within the system and potentially within other trusts, it's to sort of pick up on that. And can you track that in terms of SAIs when they're... Well, it's and this is part of the issue with this is that cervical screening, and I'm Tracey will get this, but cervical screening started a time ago, but the service has improved and changed and modified as it's gone through, and the standards have improved as learnings come through across the UK. So they would have put new standards and guidance in, and then thought about the learning audit, then that came in on various stages. So the further you go back, there's less and less stuff, because the whole system has been improving. So 2019, I mentioned there was new guidance that then provided a new classification. There was further guidance was issued last year to tighten up again in the categories I've just talked about, to bring that forward. So the whole system moves forward, and that's bringing learning across the whole the UK. System, so it's sort of standardised. So so some the standards we have now weren't the same system that was in place back, and that's the challenge. The further you go back, some of this didn't exist. And just then in terms of the staff and the management who might have been in place at time. Well, one of the issues, as I think I mentioned, is that the new staff had come in and were looking at that and managing the service, and they picked up the issue. And they brought forward the previous staff had retired or left, or for whatever reason. So that's one of the challenges, I suppose, of that particular thing in this case, is the new staff had spotted something that doesn't look. I suppose it's fresh eyes is always helpful. And so up until this point then, some of the maybe senior management who might have been involved at the time then, they haven't been sort of contacted. Those people, there's entirely different people running the service now, so they've left the trust. And that's one of the challenges, I suppose. Yeah. It's just to help to get to the bottom of it all and help with the learning, of course, longer term. Thank you. Okay, thank you, Orlia. Look, I appreciate this has been a very, very lengthy session, and there's a lot of people here who've been actually with us the whole day. So we do really appreciate the time. We know how difficult this is. We know how difficult it is, especially for the women and their families. And that's why we have dedicated so much time to this issue. We need to get to the bottom of it. We recognise it's multi-layered. I think even from what we have heard today, there's so much more to it. And I think that's the concern, is there's still so many unanswered questions. And that's why we need to pursue that very, very thoroughly. So thank you all for coming today and for bearing with us, because I think it's been really, really important, and it's important that everyone has had an opportunity to ask questions that they need answers to and to explore the issues. And I'm sure we'll potentially hear more at different stages from you all. So thanks very much. Thank you. Thank you. Members, I'm just going to propose a very short suspension because there's a wee bit of moving about to do with equipment and that. So if I can get agreement, just a few items, if I can hold people just to get through those last couple of bits. The Deputy Chair is going to take over. On Vapes Bill, if I could refer members to the draft committee report at page 172. If anyone has any comments they wish to make at this stage.
I think we've heard it. It's about another.
This will be the quickest thing, yeah. But just to remind or advise that the plenary debate is expected to take place Monday, the 3rd of February. Are members content to agree the report is drafted?
Yes.
And are we content that the report is published? Yeah. Item number 8 is the SL1, the Health and Social Care Pension Schemes Amendment Regulations, NI 2025. If I could refer you to page 188. The Department is proposing to make the Health and Social Care Pension Schemes Amendment Regulations, NI 2025, that will increase member contribution in order to meet the required scheme yield and correct pre-existing errors within the HSC pension scheme regulations. The regulations are subject to negative resolution procedure and will come into operation on the 1st of April 2025. Are members content with the merits of the policy and the Department makes the statutory rule? Item number 9 is correspondence. If I could refer you to the correspondence list at page 216 and the correspondence beginning at page 217. Just to refer members to the Belfast Trust response at page 287 on the early years service. And that's, I think, in response to the issues that we raised with the registered childminders and the medicals. Diane?
Yes. So, just, I know that you and I were at this meeting, but I can't. This was the Childminders Association and the fact that trusts could access medical records of childminders.
So that was the issue they raised, but the trust have come back and said that it's a consent. They have to give consent, and that they're not.
So can we send that to those folks
can we share that with them?
And ask for them to come back to us?
Yeah.
Because I'm pretty sure that that's not what they said.
It's different to what they've said, yeah. So if I was thinking that, no, that's fine, no problem. Just for them to move on then to the reply from the Belfast Trust providing an update on the new maternity hospital, page 3 in your table papers pack. Members, any comments in relation to that?
Not at this stage. I'll be glad to know.
Thank you. Are members then content with the suggested actions on the correspondence list?
Can I just bring one up very quickly? So it's the draft equality impact assessment on the budget. And the table 2 refers to 7.806 billion recurrent expenditure that is simply being rolled on. Have we ever got a breakdown of that? Because I kind of think that we sort of think that this is what we do every year in health, so we must always continue to do it, but we never know exactly where that money goes. Yeah. So if we have got a breakdown, if somebody in the committee can send me the breakdown. If not, can we ask the health department for it? And with that, I finished.
Share that. Okay, no problem. Thank you. Item number 10 then is the forward work programme. If we refer you to the draft plan at page 356, are members content to note the briefings as set out? Yep. Have any members any other items of any other business? Any items of what?
Sorry, did we agree 7 and 8 or while I was out there at the bathroom, or did we agree to skip them?
No, we've done
just agreed them.
Yeah, was there?
No, that's fine. That's grand.
Yeah. There's nothing coming. Nobody had any issues. Any items of?
No,
I can't get these words. Any other items of business?
Can I just? I give my apologies for next week's meeting. Placement board development days, so I won't be here.
Okay, so
I will forget to let you know, Keith, and I'll let Liz know, respecting that she should do really not her job.
So the next committee meeting is the Thursday, 30th January at 2 p.m. in room 29, and the meeting is now adjourned. Just to thank everybody, I know that was